All right, folks, we're going to go ahead and get started. So with that, I think we're at a good spot. I know the majority leader will be right back. She's coming through the door as we speak. So with that, Committee Secretary, if you could please call the roll. Thank you.
Assemblywoman Benitez Thompson. Here. Assemblyman Frierson. Here. Assemblywoman Gorlow. Assemblyman Hafen. Here. Assemblywoman Howdigi. Here. Assemblyman Levitt. Here. Assemblywoman Miller. Here. Assemblywoman Monroe Moreno. Here. Assemblywoman Peters. Here. Assemblyman Roberts. Here. Assemblywoman Titus. Here. Assemblywoman Tolles. Here. Assemblyman Watts. Here. Chair Carlton.
I am here. Good morning, everyone. We have a lot to do today. It's going to be a long day, and there's going to be a lot of different moving pieces. We have budget implementation bills that still need a hearing, and we have other bills that we do need to process. So with that, if you are a Senate member, there's no need to wait in the room. We'll be sure to give you a heads up if your bill comes up. There's limited space in all the rooms, so we want to make sure that we can accommodate everyone and have a nice flow throughout. As I said yesterday, we'll be happy to give you a heads up. But with that, today, as far as the lay of the land goes, the first bill up will be SB 380, and then the second bill up will be SB 420. 420, since it did not go to the policy committee in the assembly, we'll be giving it a little more time and a little more latitude to make sure that everyone has their voice heard on the record. But we're going to keep it tight, and we're going to keep it to the 2 minutes for everyone. When you spend 45 minutes to an hour on a bill in Ways and Means the last 4 days, you're basically spending a whole day on a bill. So we're going to keep it real close and real tight and get it done, and there's no intention to move the bill today. So with that, I just wanted to make that perfectly clear, because it's a big piece. It's an important bill, and we just want to make sure that it has the time that it deserves. So with that, I'm going to go ahead and open up the hearing on SB 380. The chair of Senate Health and Human Resources needs to get to Finance, so we need to get her in and out of there so Finance can get all the things that they need done too. So good morning, Senator.
Thank you, Madam Chair, for the opportunity to present this bill and for the discretion to go first today. I know that that is a significant gift on the fourth day of the fourth to the last day of the legislative session. My name is Julia Ratty, and I am here today to present SB 380. Today I am presenting on behalf of the Interim Committee to study the cost of pharmaceuticals. And I cannot do this work without just briefly taking a quick nod and thanking Senator Ivana Cancela for her good work on this issue and for leaving me this wonderful gift of the bills of the Interim Committee on Pharmaceutical Costs. SB 380 continues the work that was really groundbreaking work that was done in the 2017 session to shine a bright light on and bring more transparency to how we come to the costs of pharmaceutical drugs. You will probably all recall that in that session we started by focusing on one of the drugs that many people depend on, that was in the news quite a bit at that time, and that is a big cost driver for healthcare costs in the state of Nevada, and that would be diabetes drugs. In 2019, we built on that and we added asthma. And in 2021, what we seek to do is to modernize the program, if you will, make sure that staff has the resources that they need to both collect the data and to get meaningful information from the data, and to expand the class of drugs to those drugs that are clearly going up in price and I'm going to speed up my presentation. It's the third floor. I don't think I've ever been on anything but the first floor in an earthquake. So that was fun. That's a pretty good one. Okay. Yeah, plexiglass. All right, well, important business happening today, so we're just going to keep going. All right, so to bring it home, this bill basically does these things. It removes the requirement that the department compile a list of essential asthma drugs. So we think that we've gotten where we need to go on all asthma, and we're taking asthma off the table. It requires the department, in addition to the list of essential diabetes drugs, so we're keeping diabetes drugs, that program is still important to us, to compile a list of prescription drugs with a wholesale acquisition cost exceeding $40 for a course of therapy. So a course of therapy could be a month of pills, it could be one pill, it just depends on what the defined course of therapy is for that drug. So this is the wholesale cost of $40 and have undergone a price increase of 10% over 1 year or 20% over 2 years. So we're narrowing down the class of drugs that we would like to have more data and more information and shine a brighter light on from a transparency standpoint to the diabetes drugs, which are still a significant cost driver for the state, as well as now any drug that is more than $40 wholesale acquisition cost for a course of therapy and, not or, and has a 10% increase over 1 year or a 20% increase over 2 years. That's the most significant change to this bill. In addition, it adds wholesalers as a required reporting entity. So what we've learned about pharmaceuticals over time is there's a whole bunch of players in the chain, right? And so we're wanting to get a little bit more information on what's happening with wholesalers. It expands the information that a manufacturer is required to report. That is in sections 11 and 12 of the bill. It expands the information that a pharmacy benefit manager is required to report. That's in section 13 of the bill. And again, we're talking about all these supply chain issues, right? It's not just the manufacturer, it's the wholesaler, it's the PBM. And it requires the department to conduct an annual public hearing based on the report findings. So we want to make sure that the public is hearing about what we learn. We've done some updates on definitions for unit and manufacturer, just to make sure that we're getting that right in the law. And then it maintains existing penalties set forth in NRS. So we've been collecting penalties for those who do not comply. And we've collected some of those penalties. And knowing that we're still in a fiscally tight environment, what we are suggesting from a fiscal note standpoint is that we use the penalties that have been collected to date to cover the costs of the transparency program in this biennium. There's about $1 million in the account right now. The cost to do this program for the next 2 years is about $770,000, you can see on the fiscal note. So we would use the bulk of those penalties so that we don't have to touch the general fund in this cycle, and there would be some remaining penalties left over. I will just say right now, we do not know if that is sustainable going forward. We really hope that people will comply and continue to do their reporting. And so the next governor and the next legislature would need to decide, is this something that we now want to put in the base budget, or are the penalties an ongoing and sustainable form of funding for this program? But as of this biennium, the penalties will cover the cost. So with that, and knowing that time is always of the essence here, I will stop. I do have Dr. Slamowitz with me, who is head of all things pharmacy for the Department of Health and Human Services, who is also celebrating her 15th wedding anniversary today. Congratulations, Dr. Slamowitz.
Good morning, Dr. Slamowitz. Congratulations. So with that, I guess some of my questions are, and I've heard some conversations around this bill, and as far as where we're going. So I believe the bill was amended in the Senate to address some of these things. So I want to understand the $40 course of therapy a little bit better, I believe.
I'd be happy to. Again, Julia Ratty for the record. As the bill came out of the committee, and hat tip to the committee, who were being very ambitious, they wanted to do all drugs. And all drugs would have clearly have crushed the program. We couldn't afford the number of staff that it would take to analyze the data on all drugs. And that would have been quite the burden for the industry. Okay. And so through lots of conversations, and this bill, we're on a, which reprint, oh, actually, we're not doing so bad on this one. Lots of conversations, lots of stakeholder conversations, lots of conversations with the industry on this one, multiple iterations of it that I guess we just moved through iterations and working groups, not necessarily in amendments. But in the final amendment, we felt like the best focus was that price point. Okay. What we really want to know is, at a certain level, they're too cheap for it to matter, right? So $40 seemed like a reasonable price point. And then that the price is going up 10% in 1 year or 20% in 2 years gives us, that's going to narrow down the universe of drugs that we're looking at and hopefully give us information on those that are a significant cost to a family. And $40, again, that's a wholesale number, not a retail number. And for many of us, that may not sound like a lot of money, but for many of our seniors on fixed income, people with a disability, that's a significant amount of money. So we felt like it was a good starting point. And then growth, 10% or 20% growth in prices. Plus keeping the diabetes program intact. And the diabetes program stays intact completely because we've got 2 years of good data. And so we're not tweaking that program at all because we want to keep that data stream for a while to make sure that we've got those good apples to apples comparisons for a couple of years, because we learn things from that as well.
All right, Senator, and I guess my next question is going to be in the unsolicited fiscal note. You're basically saying that the dollars that they have now can cover that. My question is, I've watched a lot of bills come through in the last 100 or so days, and there's a lot of responsibilities being given, and we know we always need resources to get those things done. We can have all the great policy in the world, and we can fund it, but if there aren't the people to actually get it done, we're not going to get the data that we need next time. So within the unsolicited fiscal note, are there positions included in that? And I'd like to make that clear, that what those positions are, because I think it's really important when we do these things to give the folks the resources that they need to get it done. So are those positions included?
Thank you, Chair Carlton, for that question. It's a really important question. Julia Ratty, for the record. I will say that the legislature was, with no judgment to pass decisions, but very enthusiastic about getting this program done, as was the agency. And so they absorbed some workload in the past 2 bienniums. And so one of the things that was very important to me was to sit down with staff. So this bill started without a fiscal note. And I don't think it's very often that you'll see a legislator go back to the agency and say, I want a fiscal note. I want to know what it's going to take to do this, because collecting the data is helpful, but if we don't have the people to analyze and process the data and get to insight, then it's not as helpful as it could be. So we had serious conversations, and I'd like to turn it over to Dr. Slamowitz, who can talk about what the workload is and what how she's staffing it.
And thank you very much. And I just want to make sure, because I saw the advanced pharmacist on there, and I saw the management analyst and the notations on that. So those are actually encapsulated in the fiscal note. So it would not be in addition to. It's already been addressed.
Correct. We went and sought an unsolicited fiscal note to give us the real costs.
I've been there, done that. We just need to make sure it gets done. So, Dr. Slamowitz, just very briefly, if we just go over these positions, because they're already in there, we know what's there. We just want to understand. Thank you.
Sure, thank you. So Beth Slamowitz, Senior Policy Advisor on Pharmacy for the Department of Health and Human Services, for the record. So the 2 positions that were requested within the unsolicited fiscal note, there is a advanced pharmacist position as well as a management analyst position. Right now, as Senator Ratty pointed out, we have absorbed, we don't have any designated staff that's doing the work. We have absorbed the work and relied on staff within other programs as well as contract work to help with the collection of the data, a lot of the communications that occur on a daily basis, and other aspects of the program that are required to put out the annual reporting. The advanced pharmacist position really would give us the expertise and the knowledge to understand the complexities of the supply chain, to be able to comply the lists of the essential drugs and analyze the drug files, and also to give some oversight to the program. That position would actually supervise the management analyst position. The pharmacist that would be managing the program would also be responsible for the analysis of the information that's provided by all of the reporting entities, and then be able to develop and submit the annual reports as required, as well as to be able to participate in the public hearings, as well as the high level and complex discussions that take place with not only stakeholders, but as well as legal counsel that occurs with some of the reporting entities when that's necessary. So that position would be vital to the sustainability of the transparency program. Having that staffing in a permanent position would definitely assist in moving the program forward to be able to inform and change any future policy. The management analyst position would help with all of the reporting and the templates, some of the data analysis, as well as collecting all of the reports that come in, and to be able to also provide communication. We don't have any administrative assistance or anything like that for the program, and we do get multiple emails, phone calls, and all kinds of communications that need to occur on both a daily and a monthly basis. And just to kind of give you an idea of the amount of work that comes in, for this last reporting period, we're getting ready to put out the 2021 report on June 1st. There were over 1,500 drugs that needed to be analyzed and put into reports. And then each one of the reporting entities, the PBMs, the manufacturers, as well as the drug reps, all had to submit reports on those drugs. And then each one of those had to be analyzed. There were various communications back and forth. And then, of course, the final completion and submission of the end result report. So it is quite a bit of work to manage, and with adding additional reporting requirements as well as additional drugs to report on, the work will just increase, which is not a bad thing because it'll give us more data to inform our policy. But it certainly would be helpful to have sustainable resources as well as appropriate analytical tools. And that really is what the fiscal note is addressing.
All right, and I just want to make sure that we've got it clear for the record that these are going to be contracted positions and that they're going to come out of the, and I believe it's a non-executive budget that they'll be coming out of because we don't put permanent positions into that. So we're contracting to see how things happen for the next couple of years for those positions. And then then we'll see where the program is in 2 years from now. You'll be able to reevaluate and see if those positions might be needed on an ongoing basis. Do I understand that correctly?
Correct. Right now, the penalty funds that would be used are in a non-executive budget account, and that would be used to sustain those positions for the next biennium. And then hopefully we'd be able to actually put the program within a consistent budget going forward. So
Okay.
they would be permanent positions.
We just want to make sure we've got a good record so that we don't have an issue with positions at another time.
Madam Chair, if I may, I've made a rookie maneuver. I should have said at the very beginning that we're working off of the proposed amendment 3408 to Senate Bill 380 mock-up, which is an exhibit on your committee's page and everybody should have access to. I apologize for not acknowledging that earlier, and the fees are in section 18 of the bill. Julia Ratty for the record.
All right, we're just making sure that all the pieces align. We don't want to have a domino that doesn't fall over. We've got to make a straight line. So, all right, thank you very much, Senator. We appreciate it. We'll make sure that everything's buttoned up on this as we move forward. We wouldn't want to miss one. So with that, this is the hearing for SB 380. And thank you, Ms. Slamowitz, for being here. And we'll go ahead and open it up. So with that, is there anyone here in the room in support of SB 380? Oh, I'm sorry. Did you want to ask? I'm sorry. I apologize, Senator Ratty. Go ahead. You guys got to speak up.
I thought that was pretty easy.
I mean, you really do need to speak up, otherwise I'm not going to know you want to ask a question, okay? We're at that stage of the game.
Thank you, Madam Chair, and thank you, Senator, for the presentation this morning. Just curious, I was on the Health and Welfare Trust representing management at Metro, and we had a lot of things with healthcare, and prescription drugs were always an issue for a lot of our members. And I see this as a transparency bill. It has PBMs and manufacturers having to do reports. I'm just curious as to why we didn't include insurers, health trusts, because there's a lot of rebates that are given that really reveal the cost of medicines, and some of that's passed on to members. And I'm just curious as why that wasn't included.
Thank you, Julia Ratty, for the record, through you, Chair Carlton, to you, Assemblyman Roberts. It's a great question, and we did start with insurers in this bill. At the beginning of the session, I was doing a lot of work on two bills. This bill on behalf of the Interim Committee on Pharmaceutical Costs, but then I was also had the privilege of having the Patient Protection Commission bills come to the Senate side first, and there's the All Payers Claims Database. And when we were looking at workload and where were we going to get the best transparency, the All Payers Claims Database is 100% insurance data, and we get to see all of the claims. And so we're looking at, okay, well, how much do you really ask these insurers to be sending us information, and how many different places and how many different forms can they put it in? And so I really felt at the end of the day we were going to get the best bang for our buck by having the All Payers Claims Database go forward, where we're getting every claim on all healthcare, including pharmaceuticals, and then this bill focusing on the rest of the supply chain. So it really was a matter of, in conversations with stakeholders, how much can we ask? How much can we really process? And so tried to hit the sweet spot with the two, but you're going to get insurance, you're going to get information from the insurers in the All Payers Claims Database.
Thank you, Madam Chair. And that would be a transparency piece as well in the database, because I apologize, I'm not familiar with that part of it.
And there's so much going on right now, Assemblyman Roberts. That would be SB 40 that this committee heard yesterday.
Okay.
I think that was just yesterday.
I forgot.
I'm not trying to, there's a lot going on.
Okay.
But that is, and it was mostly focused on the fiscal note in yesterday's hearing, so you probably didn't hear it in the policy committee, but the All Payers Claims Database is exactly what it says. It is all claims from all insurers going into a database that can then be analyzed by the staff.
Thank you, Madam Chair, and thank you for the answer.
And you're welcome, Mr. Roberts, and I apologize, but please do speak up, because we're kind of just trying to plow through everything here. So with that, other members, questions at this time for Senator Ratty, Assemblywoman Peters?
Thank you, Madam Chair. And I have kind of a similar question, but related to how we're going to bring those two data streams together and the capacity for that, right? Are these two offices working tangentially together? That's.
Thank you for the question, Assemblywoman. Again, Julia Ratty, for the record. One of the things, so we're data geeks. So one of the things that I am most excited about this session is, and again, we would have heard about this more in the budget committees, the money committees, is that the Department of Health and Human Services is creating an entire data team. And they are moving towards a much more coordinated, professional approach to data collection and data usage. And so these tools that we're giving them, pharmaceutical transparency, all payers claims database, some other things that have happened during the session, are going to give them a wealth of data that now will be in a department that is completely focused on analyzing data. So I'm more confident today than I have ever been that we are going to get good, meaningful, coordinated data. But if you need more than that, I would ask Dr. Slamowitz to speak to it.
And Assemblywoman, we put the Office of Data Analytics under the director. So that's the umbrella, and now all these pieces of legislation will all go under that umbrella.
The data geek in me is so happy right now.
We're happy you're happy. Okay. No more decisions by anecdote. That was my goal. Okay, so with that, any other questions at this time? Not seeing any, Mr. Please.
I'll keep it very brief.
We are on a clock.
So you said that SB 40 and SB 380 were going to work with this data team now. Would that also be true with SB 5 and everything else that we've been, lots of moving parts that passed out of this committee yesterday, so I just want to make sure that everything's going in the right direction.
Dr. Slamowitz, can you speak to the data analytics? I know that's not quite your department, but I think you have familiarity with it.
Sure. So Beth Slamowitz for the record. So yeah, definitely not my wheelhouse as far as all of the analytics goes, but really the drive is to tie all of these pieces together. Right now, at least with the drug transparency program, the only utilization really that we have to kind of look at how these drugs are being used in the state is Medicaid utilization, which although it is, about a third of the state, in terms of utilization, it still doesn't give us a really broad picture of how these drugs are being used and what kind of utilization we're looking at as far as trends. So having access to the claims information from the All Payers Claims database, not only does it give us an opportunity to look at additional utilization, but it also gives us an opportunity to kind of do a cross-check that what the PBMs are reporting is actually happening, so that what we're seeing that the PBMs are claiming as far as cost of the drug, as far as rebates being received, then we can go back to the All Payers Claims database. If those PBMs are reporting that pharmacy data for those health plans, that we have a cross-check now to be able to look at that and actually verify the data. So I think all of those pieces coming together in an analytics team, and also having those resources that understand how to do the analysis, it definitely takes a certain subset to look at, to be able to understand SQL and to understand the drug files that come in are not in any kind of tangible form. So it's really important to have people that know what they're doing to be able to pull the data in accurately and then to do the appropriate analysis, while also having the clinical resources to kind of put those pieces together. Hopefully that helps.
Thank you very much. So with that, not seeing any other questions at this time, thank you very much, Senator. Want to get you back to Senate Finance as soon as we can. So with that, I'll go ahead and open it up for support, opposition, and neutral to complete our hearing process on SB 380. Those here in the room in support of SB 380, please come forward. Seeing no one, anyone on Zoom? Seeing no one, broadcast services, do we have anyone in audio in support of SB 380, please?
If you would like to testify in support on SB 380, please press star 9 now to take your place in the queue. Caller with the last 3 digits, 338, please slowly state and spell your name for the record. You will have 2 minutes and may begin. Caller 338, please press star 6 to unmute.
Good morning, Madam Chair, members of the committee. This is Priscilla Maloney, Maloney, with the AFSCME retirees. I don't know, Madam Chair, if anyone is here from PEB this morning, but we are in support of this bill as written. We've also taken a look at the amendment, and PEB is still very much in there in Section 2 of Amendment, I believe it's 426. But globally and briefly, we are very much in support, even as amended, of this bill. Thank you.
Thank you very much. Anyone else in support of Senate Bill 380?
For anyone who just joined the call, if you would like to testify in support on SB 380, please press star 9 now to take your place in the queue. Chair, there are no more callers in support at this time.
Thank you very much. Is there anyone in the room in opposition to SB 380? Seeing no one on Zoom. Is there anyone in opposition on the phone line?
If you would like to testify in opposition to SB 380, please press star 9 now to take your place in the queue. Caller with the last 3 digits, 194. Please slowly state and spell your name for the record. You will have 2 minutes and may begin.
Tom, Tom, McCoy, McCoy. On behalf of the thousands of patients with one or more chronic condition diseases in Nevada, we share our concerns with SB 380 as it now reads. The Nevada Chronic Care Collaborative supports transparency for prescription drug pricing, but for patients to truly benefit from transparency policy, notwithstanding SB 40, the policy needs to apply to all players in the supply chain spectrum, parties that impact what consumers pay when checking out at the pharmacy counter. Excluding insurers, as SB 380 does, from the same reporting obligations is not true transparency and offers only half the pricing picture. SB 380 does not address the most important factor for patients with chronic illnesses, out-of-pocket cost. Moreover, fails to address what pharmacy benefit managers and health plans do not pass on, rebates and discounts that they receive from biopharmaceutical companies. Nevada Chronic Care Collaborative is a network of state and regional advocacy organizations advancing public policy that improves the lives of those Nevadans living with chronic conditions and diseases. NCCC encourages the committee to consider these factors as you determine the future of SB 380. In its present form, the legislation does little to improve access and affordability of prescription medications for Nevada patients. Thank you.
Thank you. Is there anyone else in opposition on the phone line, please?
Caller with the last three digits, 300. Please slowly state and spell your name for the record. You will have 2 minutes and may begin.
Good morning, Madam Chair and members. I'm Brett Michelin with the Association for Accessible Medicines. AAM represents the generic and biosimilar manufacturers. And I have really three main points I'd like to make. First, I think the state needs to consider what it is going to be paying for with its fine and penalty monies. The state will be aggregating data and reporting information submitted by manufacturers with a wholesale acquisition cost of $40 that increases by 10%. This is not going to capture the high-cost drugs. In fact, it will generally only capture generic drugs, which have saved Nevada $2.4 billion in 2019 alone. For example, this bill will capture drugs that cost $1.33 that increase by 13 cents for a drug taken once a day. For a drug taken 3 times a day, it will capture drugs that cost 44 cents and increase by only 4 cents. However, we need to consider what it won't capture. Consider Humira, real-world example. It increased in price, according to Medicare Part D, by 44% over 5 years. It won't be required to report under this bill because that is just, on average, about 9%, just below 9%. Another real-world example, brand name Ultram. Its wholesale acquisition cost is roughly $300. If it increases by $30, it won't have to be reported. However, generic Ultram costs about $3. If it increases by 3% or 3 cents, it will be reported. So this bill is not going to capture the drugs that are driving the increase in costs of medicine. Also, the WAC price is on the generic side, it's very different. The WAC does not reflect what the patient is actually going to pay at the pharmacy counter. When you have multiple manufacturers making the exact same drug, regardless of what the WAC price is, the state and the plans, they don't even negotiate with wholesale manufacturers for the wholesale price. That's done on a national sales price. So again, the WAC is not going to reflect what patients pay. AAM did suggest amendments, and would be neutral on a bill that actually differentiated between brand medications and generic medications with thresholds that actually represent and would capture just the high-cost drugs. That's similar to what other states have done in passing
you
this
could
type
begin
of
to wrap
legislation,
up,
typically
please.
with $100. Absolutely. I have just one more quick point. Thank you. Appreciate that. This information has already actually been captured by California. They've done this work for Nevada already. And from California, we know that even with the most expensive generic drugs, they are 25% of all prescriptions. They're only 8% of the spend and less than 1% of the premiums. So this bill is not going to capture the information that Nevada needs to consider other proposals to reduce the cost of medicine. Thank you.
Is there anyone else in opposition on the phone line, please?
For those of you that just joined the call, if you would like to testify in opposition to SB 380, please press star 9 now to take your place in the queue. Chair, there are no more callers in opposition at this time.
Thank you very much. So with that, is there anyone in neutral in the room? Seeing no one in neutral, is no one on Zoom. Is there anyone on neutral on the phone line, please?
If you would like to testify in neutral on SB 380, please press star 9 now to take your place in the queue. Caller with the last 3 digits, 372. Please slowly state and spell your name for the record. You will have 2 minutes and may begin.
Thank you, moderator. My name is Bashor Lissek, spelled Asherlisec. SB 380 is a byproduct of the Interim Committee on Prescription Drugs. While we are disappointed that many of our measures did not get vetted by the 2021 legislature that would have truly assisted all Nevadans with their prescription drug costs, Pharma appreciates the opportunity to work with Senator Ratty on SB 380 to address our primary concerns with the measure. Thank you and happy anniversary, Dr. Slamowitz.
Thank you very much. And thank you for being perfectly neutral right down the line. We appreciate that courtesy. Are there any other callers in neutral on the phone line?
For those of you that just joined the call, if you would like to testify in neutral on SB 380, please press star 9 now to take your place in the queue. Chair, there are no more callers in neutral at this time.
Thank you very much. So with that, any closing comments, Senator Reddy? I don't think any are needed, but if you want to do a 2-sentence
Thank
close?
you. Again, I appreciate the time of the committee on this. I will say that we worked with lots of stakeholders. We accepted lots of amendments. I think you see that reflected, that there's not a long line of people here to testify in opposition. I think the folks we disappointed the most were the folks who represent generics. And we think there's a good argument for keeping generics in for at least 2 years, and then that can be revisited. And again, we'll get the utilization data from the All Payers Claims Database, which will help us, hopefully, if that gets across the finish line, which will help us as well. So again, thank you so much. I appreciate your time today.
Thank you very much, Senator. So next we had SB 420 in the queue. With our little earthquake earlier, it set off the sensors in all of the elevators, so none of the elevators are working. So the majority leader is making her way from the first floor to the third floor through the stairwell right now. So everybody have just a few moments of patience. We wanted to go nice and slow. We don't want to have a baby today. So we'll just stand at ease for just a moment. Oh, here she comes. You made it. Congratulations. As soon as I felt that earthquake, I started thinking about the sensors on elevators. Yeah, on the third floor, it had a little bit different feeling to it. The plexiglass was really interesting. Take a moment. Get it together. Take a moment. We're good. Oh, it's Friday. I forgot.
Good morning, Chair Carlton and members of the Ways and Means Committee. For the record, my name is Nicole Cannizzaro. I represent Senate District 6, which is located in the northwest portion of the Las Vegas Valley, and I'm pleased to be here with you all today to present to you Senate Bill 420. I do have joining us today, Chair Carlton, 2 co-presenters, which I promise will be very short, but I think can provide some context on this bill if you will allow. I do have Shaniqua Hawkins of Care with Purpose Medical Center in Las Vegas, and Wendell Potter from the Center for Health and Democracy, who can join us via Zoom. I believe they should be connected this morning. Also here to assist with technical questions as we walk through the bill and are able to answer questions for the committee, I have Stacy Weeks from Arera Health. One of the problems and one of the most common concerns that I hear when I'm talking to constituents at the doors, whether it is in Senate District 6 or whether we have folks here, is the cost of healthcare here in the state. That is such a huge issue for so many families, and polling and studies do reflect this reality. According to the Kaiser Family Foundation, the cost of healthcare ranks at the top things that Americans worry about, and it affects every aspect of patient experience, from decisions about whether to even seek care to the impact of medical bills after receiving care, and importantly, it affects decisions about insurance coverage. It's not just families that are concerned about the cost of care. In research that was released recently, the Kaiser Family Foundation also found that more than 90% of business leaders surveyed believe that there is a greater role for the government to play in controlling healthcare costs and providing coverage options, including potentially public options. Now, in the years following the passage of the Affordable Care Act in 2010, Nevada also expanded Medicaid and began offering private health insurance on the Silver State Health Insurance Exchange. The number of Nevadans without health insurance did decline. However, the uninsured rate in the last few years has remained stubbornly consistent and among the highest in the nation at approximately 11%. In fact, there are nearly 350,000 uninsured Nevadans, and our uninsured rate, despite being one of the states that did in fact expand Medicaid coverage, is still 7th highest in the nation. We pay some of the highest costs, but still struggle with disappointing health outcomes. What Senate Bill 420 hopes to address with respect to that issue is to expand affordable, accessible, quality health insurance options for all Nevadans. As members of this committee may remember, in 2017, the legislature did pass a Medicaid buy-in legislation. That legislation was ultimately vetoed by Governor Sandoval, and there was some additional ongoing conversations about how to address healthcare costs here in the state. At the end of last session in 2019, we passed Senate Concurrent Resolution number 10, which provided for an actuarial analysis in the interim, and that data has led us to this point, an introduction of Senate Bill 420. This bill also, I believe, comes at a critical time. We are more than a year into a global pandemic that has resulted in job loss and loss of health insurance, and people are struggling to ensure they will have access to health care if they get sick. Now is an opportune moment to take advantage of the state's considerable bargaining power to make health care more affordable and more accessible by enacting this particular bill. This bill improves access to health care in two key ways. First, by requiring the establishment of a public health insurance option. And second, there are also provisions in here that make various changes to Medicaid to expand access to care. Those are two separate pieces of the bill. With your permission, Madam Chair, I would like to turn it over first to Shaniqua Hawkins, who is joining us via Zoom, and then Wendell Potter.
That would be just fine. Please proceed.
Good morning, Madam Chair and members of the committee. Thank you for the opportunity to speak today. For the record, my name is Shaniqua Hawkins, spelled S-H-E-N-A-K-W-A, last name H-A-W-K-I-N-S. I am speaking in favor of SB 420, and thank you, Majority Leader Canizaro, for allowing me this opportunity also, and for proposing legislation and for having me here to describe why it's needed. I am a healthcare provider and a small business owner. I am an advanced practice registered nurse, and I run Care with Purpose Medical Center here in North Las Vegas. We predominantly serve people of color and low-income communities, including a large population of homeless clients. I have submitted a full remark for the record. It's in written form. So out of respect for our time, I will just briefly say this. I personally know what it's like to lose a job and with it health insurance. I lost mine at the start of the pandemic when the clinic I worked for shut its doors. Our practice now that we do see and we treat many people in this very same situation. I've been a registered nurse for over 20 years, including in emergency and trauma centers. I know that not having health insurance means that people end up needing expensive emergency care because of conditions that have been treated proactively, if it had been treated, proactively, and if they would have been able to afford insurance earlier, we could have prevented some of these issues. The Nevada public option helps make preventative medicine more affordable and accessible. As an APRN, the move toward pay parity is great. There is much inequality in our existing system. That's part of what inspired me to open my own practice and serve historically underserved communities and populations. We are providing the same level of care with preventative medicine and management of chronic diseases such as hypertension, diabetes, and cholesterol issues that are especially problematic in communities of color. Pay parity would help me keep my clinic open long-term, and I appreciate this step in that direction. It also helps provide, like us generally with getting more people access to health insurance that will more adequately reimburse providers. There are many other reasons why I support this bill, but in the interest of time, I will end by reiterating that this bill will help communities like the one that my clinic serves, and I ask that you and urge that you pass this bill to help us. Thank you.
And thank you very much, and we'll make sure to put your comments in the support section of the hearing. We're still kind of in the presentation section of the hearing. So, Majority Leader, do you have anyone else wishing to be in the presentation section and then walk through the bill?
Yes, Madam Chair, with your indulgence, if the committee would like, we should have Mr. Wendell Potter. I think he is also going to provide just a sort of an explanation of why this type of legislation is important.
Okay, thank you. Please proceed.
Madam Chair and members of the committee, my name is Wendell Potter, Wendellotter. A dozen years ago, President Obama told the joint session of Congress that a public option was necessary to keep insurance companies honest and hold them more accountable. Without the competition that a public option would provide, he said, it's easier for insurance companies to cherry pick the healthiest and drop the sickest, to overcharge small businesses and to jack up rates. He went on to say that, as one former insurance executive testified before Congress, insurance companies are not only encouraged to find reasons to drop the seriously ill, they're rewarded for it. All of this in the service of meeting what this former executive called Wall Street's relentless profit expectations. That former executive was me. Not long before that speech, I had left my career as head of communications at Cigna after a crisis of conscience. The powerful insurance industry was able to strip the public option out of the Affordable Care Act to protect profits. In the years since that bill was enacted, insurance companies have only become bigger and more emboldened in their efforts to keep people from getting the care that they need. Insurers have also become some of America's most profitable companies. In fact, most of them have posted record profits during the pandemic. Those record profits are the result of barriers that insurance companies have erected that make it more and more impossible for people with insurance to get the care that they need. Hundreds of thousands of your constituents still cannot afford health insurance because of ever increasing premiums. Many others who do have insurance cannot even pick up their prescriptions because insurance companies now make them pay, in many cases, thousands of dollars out of their own pockets before their coverage kicks in. It isn't just ordinary folks who are being fleeced by insurance companies. So are employers, most of whom were hard hit during the pandemic. A recent survey by the Kaiser Family Foundation found that the CEOs of even America's biggest employers now want the government to play a bigger role in bringing down the cost of healthcare. In my old job, I helped carry out numerous propaganda campaigns to scare people about health care reform proposals at both the federal and state levels. One of the ways we succeeded was going into states and recruiting hospital executives and provider groups to serve as our messengers. It was dishonest work, which I will always regret. If I hadn't quit, I might still be writing misleading talking points for the industry's front groups, like the ones they call Nevada's healthcare future. Assembly members, how you vote on this bill will result in either more Nevadans being able to get the care that could save their lives, or further enriching the people who are bankrolling the campaign against the bill before you. You have the power to hold insurance companies more accountable and bring down the cost of healthcare and health insurance. Don't let the industry's greed keep you from doing what is right for your constituents. Thank you.
Okay, thank you very much. So with that, Majority Leader?
Yes, thank you, Madam Chair. At this point, I would like to walk through the provisions of the bill. And we'll begin with the public option piece of the bill. As I mentioned, there are two sort of separate pieces of this particular bill. So this bill specifically requires the Director of the Department of Health and Human Services, in consultation with the Executive Director of the Silver State Health Insurance Exchange and the Commissioner of Insurance in the Department of Business and Industry, to design, establish, and operate a public health benefit plan called the Public Option. The primary goals of the public option are to leverage the state's purchasing power to reduce health insurance costs for Nevadans, improve access to high-quality, affordable health care for residents, including those employed by small businesses, reduce disparities in access to care and health outcomes, and increase access to care for historically marginalized communities, and to increase competition in the individual health insurance market to improve health insurance options for rural Nevadans. Pursuant to Section 10 of the bill, the public option must be made available to all Nevada residents, both as a policy of individual health insurance through the exchange and for direct purchase. It may also be made available to small employers or their employees. And I apologize, I should have started with this, Madam Chair. I did note that we do have on Nellis, and I hope all the members of the committee have access to proposed amendment number 3463 to the second reprint of the bill. That includes some cleanup language after consultation with the State Health Exchange and the Director to make sure that what we're doing here has accurate definitions of what is included in there. And you'll see some changes to Section 10 to clarify that we are talking about natural persons in this particular bill. Section 10 further requires a public option to meet requirements established by federal and state law for individual health insurance or health insurance for small employers. To keep costs down, premiums for the public option must be at least 5% lower than the premium of the second lowest cost silver plan available on the exchange in the relevant zip code, and they must not increase by more than the Medicare Economic Index in a given year. Under the provisions of this bill, these requirements may be revised by the Director of DHHS, the Executive Director of the Exchange, and the Commissioner of Insurance if the public option is on track to reduce its premiums relative to the state's benchmark premiums by at least 15% in its first 4 years of operation. Section 11 of the bill requires the Director, Executive Director, and Commissioner to apply for certain waivers to obtain federal financial support for the public option, and authorizes them to contract with an independent actuary to assess the impact the public option would have on healthcare and health insurance markets in the state. Section 12 requires the Director to use a statewide competitive bidding process to solicit and enter into contracts with health carriers and others to administer the public option. In order to increase competition, health carriers that provide Medicaid managed care plans in Nevada must participate in the competitive bidding process. The bill also authorizes the Director of DHHS to directly administer the public option if necessary. We have added also language in there for bidding preference criteria to reward those plans who can demonstrate that their public option product will better align with MCO networks, include value-based care arrangements, and provide for adequate coverage in rural areas and underserved communities. This also requires a health carrier who is administering the public option to provide information to the Commissioner of Insurance and to obtain certification as a qualified health plan. Sections 13, 21, and 29 of the bill require healthcare providers and facilities that participate in Medicaid, the Public Employees Benefits Program, or the state's Workers' Compensation Program to enroll as participating providers in at least one public option plan and accept new patients who are enrolled in the public option to the same extent they would accept new patients not enrolled in the plan. Section 14 requires aggregate reimbursement rates under the public option to be comparable or better than Medicare reimbursement rates. It also requires the Director of DHHS to establish healthcare provider networks for the public option that minimize disruptions in care for those who do lose coverage through Medicaid or the Children's Health Insurance Program and enroll in the public option. The Director must also encourage the use of value-based payment models, reward delivery of high-quality services, and lower the cost of care throughout the state. Section 15 establishes the Public Option Trust Fund to hold certain funds for the purpose of implementing the public option. This bill makes various additional changes to ensure the public option is treated similarly to comparable forms of public health insurance. Beyond the public option, the second piece of this bill relates to several pieces of Medicaid expansion that came as a result of conversations we were having with DHHS as we were discussing the implementation and the pieces of the public option. They had a series of Medicaid expansion pieces that would help to aid with additional care for pregnant and nursing moms for both prenatal and postnatal care. And we've included a lot of these in this bill after following those conversations. So Senate Bill 420 does make some of those various changes to Medicaid by expanding coverage for those pregnant women in hope of improving health outcomes and reducing health disparities by expanding access to critical prenatal and postpartum care, among other services. As we know, here in Nevada, non-Hispanic, Black, American Indian, Alaska Native, and Asian Pacific Islander populations have some of the highest rates of severe maternal morbidity, which includes potentially life-threatening conditions and maternal complications. Rates for these populations are approximately double those for non-Hispanic whites. And in addition, non-Hispanic Black women have the highest pregnancy-associated and pregnancy-related death ratios, accounting for less than 15% of all deliveries, but 25% of all pregnancy-associated deaths and 33% of all pregnancy-related deaths. As the single largest payer of births in Nevada, Medicaid is uniquely positioned to improve maternal and child health outcomes, and it is my hope that expanding the health insurance coverage and access to care for pregnant women will improve existing health disparities and maternal and child health outcomes for moms and babies in Nevada. And Madam Chair, I would be remiss if I did not recognize that this is certainly pieces that we have included in Senate Bill 420. I do obviously have an interest in some of the types of care that come as a result of these pieces, but certainly this is not something that I want to take any credit on leading the way for. I know that we have several members on this committee even who are doing remarkable work on other bills this session and have done remarkable work in other sessions. Assemblywoman Gorlow and Assemblywoman, of course, Monroe Moreno, who have been leaders in this aspect of making sure that moms can get additional care. We were excited to include some of these pieces, obviously, after those conversations with DHHS, but I would be remiss if I didn't recognize that they certainly have been leading the way in a lot of these respects. So Section 24 of this bill enhances Medicaid services for pregnant Nevadans to ensure that more expectant parents and their children receive quality prenatal and postpartum care. It increases the income cap on Medicaid eligibility for pregnant women from the current limit of 165% of the federal poverty level to 200%. It requires Medicaid to expedite enrollment for pregnant women through a policy of presumptive eligibility, which allows certain entities to help women enroll in Medicaid without submitting a full application that includes proof of eligibility. It prohibits DHHS from requiring a pregnant woman who is otherwise eligible for Medicaid to live in the United States for a certain period of time before enrolling in Medicaid. Section 25 further expands access to care for all Nevadans by requiring Medicaid to cover the services for community health workers who provide services under the supervision of a physician, physician assistant, or advanced practice registered nurse. Section 26 requires Medicaid to cover certain costs for doula services. Section 27 requires fee-for-service Medicaid to reimburse APRNs to the same extent as services provided by a physician. Section 28 requires Medicaid to cover breastfeeding supplies, certain prenatal screenings, tests, and lactation consultation and support. And finally, in an effort to improve access to care for Nevada's rural residents, Section 30 requires DHHS to establish a Medicaid managed care program to provide health care services to Medicaid recipients in all geographic regions of the state, rather than just in urban areas, as is the current practice. The department must conduct a statewide procurement process to select health maintenance organizations to provide these services. And we want to ensure as well that under statewide managed care, rural providers and FQHCs could expect to receive at least the same rates as they are today under fee-for-service. Finally, the bill directs the exchange and DHHS to seek a waiver from the federal government to allow multi-employer health trusts to offer their plans on the exchange under certain circumstances. We have a lot of Nevadans who are covered under these plans, and they often work in industries that are particularly sensitive to challenging economic circumstances. This waiver would be an innovative way to make it easier for those plans to provide continuity of coverage to their members, leading to more consistent care and better health outcomes. Section 39 also requires the performance of the actuarial study and requires the director to apply for the waivers indicated to support the public option. Chair Carlton, we have heard time and time again that Nevadans need more affordable health insurance. We have heard from small business owners, their employees, the uninsured, the underinsured, and those who have lost their jobs and their insurance as a result of the pandemic, and frankly, who lose their jobs from other economic circumstances. They need health care, period. And that's what this bill is seeking to do. They need affordable insurance options. Senate Bill 420 does take the critical steps that I believe lead us in the right direction, that is also married with data from an actuarial study and allows us to utilize the state's purchasing power to help increase those affordable options for Nevadans. Madam Chair, the final thing I wanted to touch, two final things I wanted to touch on. In the bill as presented to this committee, there are appropriations for the public option. For the pieces on the Medicaid portions that are not savings, they have been made to read that they would be permitted as funding may become available, so you will see that reflected in the bill as well. But for the Finance Committee purposes, there is an appropriation that we did add over in the Senate for the implementation and beginning of the public option. The other thing I wanted to note is that the public option pieces would allow for procurement in 2025, with the first plan year being in 2026. I also think that that is an important note because it does provide time for us to ensure that what we are implementing makes sense. And finally, Madam Chair, I do know that Jim Penrose is here and was planning to address the committee about a proposed amendment that we have worked on with the majority leader that is friendly and that we're supportive and happy to have in 420. I think his plan was to come up during testimony to be able to explain that, unless you would like for him to come up now, but I'll leave that to the chair, and that concludes my remarks.
I think now would be better. I think it's best to have that comprehensive conversation all in one section of the bill. Since we were working from a previous, another proposed amendment. And then we do need to get into the fiscal component of it, because we believe there was an extra fiscal note attached after it left the Senate. So we want to make sure that we get that addressed. Good morning.
Good morning. Thank you so much, members of the committee and chair, for taking the time to hear me this morning. My name is Jim Penrose. My wife, Pam, is here as well. We're from Carson City. We're retired public employees, currently insured by the Public Employees Benefits Program. Pam is one of, based on my estimate, about 100 people in Nevada who suffers from a rare inherited metabolic disease that requires her to take what in statute is called an enteral formula. Because she's unable to absorb a particular amino acid and is restricted to a very low protein diet of regular food, she's required to take every day for the rest of her life, in all probability, a specially formulated medical formula that supplies her with the protein that she needs, but without the particular amino acid that she's unable to metabolize. The unreimbursed cost of that formula to us is about $9,600 a year. For a family with 2 or 3 children with PKU, which is another disease that's involved here, the cost can be, I would assume, 2 or 3 times that amount. For a middle-income family, that's obviously a substantial amount of money. Back in 1997, the legislature mandated that health insurers provide coverage for enteral formulas that are prescribed by a physician and used for the treatment of these metabolic diseases. Unfortunately, the legislature didn't attempt at that time to define what an enteral formula was. But both then and now, the vast majority of the formulas we're talking about are consumed orally. They're products that can be drunk rather than administered through a feeding tube or intravenously. Nevertheless, PEB and a number of other health insurers, both in Nevada and elsewhere across the country, have taken the position that coverage for an enteral formula is required only if it's administered through a feeding tube or intravenously, and the patient is otherwise unable to take oral nutrition. That effectively, in our view, eliminates the mandate that was adopted in 1997. So we have mocked up an amendment which is on Nellis, which amends the relevant provisions of NRS to provide explicitly that, as used in the coverage mandate provisions, an enteral formula includes, without limitation, a formula that is ingested orally to make sure that the formula that Pam and so many other patients take continues to be covered. PEB, I may say, as a matter of practice, even though it's largely a self-insured program, has undertaken in its various plans to provide coverage for enteral formulas, quote, as mandated by law. Nevertheless, as I say, they take the position that we're not talking about formulas that are administered orally. So the final provision of the amendment adds language to NRS 287.04335, which sets forth the various provisions that the PEB board is required to comply with, to make reference to the particular provision that relates to group health insurance and to health maintenance organizations. And all those changes would be effective under the terms of the amendment on July 1st, 2021, to ensure that PEB abides by these provisions during its upcoming plan year, which is called the 2022 plan year. Other than that, I'm happy to answer any questions you may have. I've submitted a letter to the committee. There's also a document from the Michigan Department of Health and Human Services that in 4 pages outlines this problem. I should add, in terms of the fiscal impact of this bill, which is this committee's primary concern, it may be that Pam is the only patient among the 75,000 or so that PEB insures who is affected by this particular problem. And we're talking 100 patients out of a population of roughly 3 million people in Nevada. So I don't anticipate that there will be, from PEB's standpoint, a significant fiscal impact. I should also add that local governments that provide a health plan through a plan of self-insurance to their employees under the provisions of NRS 287.010 are subject to the group health insurance coverage mandates, and so potentially there would be an additional fiscal impact, incremental, I would argue, to them, but I wanted to make that clear for the record. Other than that, I'm happy to answer any questions you may have, and Pam is here to answer any questions you may have of her. Thank you.
And thank you very much, Mr. Penrose. You haven't lost your mock-up abilities at all, so we appreciate that. Makes it very clear what we're doing, and since the sponsor considers it a friendly amendment, we would normally have folks come up in neutral to propose an amendment or even in opposition, but since it has been previously discussed and everybody's on board, this bill is having a very unique way through the system. So we're trying to make adjustments in the last 4 days of the session to make sure everything gets addressed. So with that, committee, Majority Leader, did you have anyone else in a presentation mode right now? Committee members, questions for the Majority Leader at this time. Mr. Hafen.
Thank you, Madam Chair.
Oh, Mr. Hafen, if I could stop you for just a moment. So the game plan is, we started at about 9, we're at about 9:26 right now. We'll go into questions and hopefully we can keep that to about 10 to 12 minutes. If possible, then I'd like to open it up for support, approximately 15 minutes, opposition, approximately 15 minutes, and then neutral, and I'd like everyone to keep it to 2 minutes. We have a lot of letters associated with this also, so they have been uploaded in Ellis. They are available for the public. So with that, I just want to give everybody the lay of the land as far as how we're going to go with this. So, Mr. Hafen, go ahead.
Thank you, Madam Chair. And thank you, Majority Leader, for bringing this forward. And we had a bill yesterday about the prenatal care, and that's a huge, huge thing for me. So I'm very appreciative of that aspect. I did want to touch base on this, on how this is going to interact with the new American Rescue Plan. Effective April 1, it increased the eligibility from 400% to 600%, and then limited the amount for insurance to 8.5%, I believe it's 8.5% of their income. So with that increase in the exchange to 600% of the poverty level, how is this bill going to interact with those changes?
No, that's a great question. Through you, Madam Chair, to Assemblyman Hafen, Nicole Cannizzaro, Senate
Please
District
go
6.
directly to the member as we work through this.
Chair.
Thank you, Majority Leader.
So that is actually a question that has come up throughout the course of discussions on this particular bill. And while I think that there is obviously a lot of good pieces with respect to the American Rescue Plan dollars and how it is helping to get more Nevadans covered on insurance, which I think speaks to exactly the problem that we have, is that there are people out there who are uninsured who need to be insured. And how do we start to address that? That is a temporary and expiration in the future situation. So this is not, I think that this actually is sort of the complement to that, right? We know that there are people out there who are underinsured or uninsured who need access to healthcare, who are willing to get access to healthcare when it's something that they can afford and something that they can qualify for and get proper coverage. I think that speaks to the exact issue that Senate Bill 420 is trying to address. But what is happening with the American Rescue Plan dollars and some of those effects are temporary. And so I think here in the state, we need to think of something that is more long-term, that is permanent, and is going to help to reduce those costs. And that's what Senate Bill 420 does. So this will operate obviously a little bit differently than what we're seeing with the ARP funds. This, I would note as well, it has a procurement year of 2025 with implementation for the first plan year to be in 2026, which allows us time to kind of get this set up in the interim and allows for there, I think, to be another option for folks who really do need that coverage after the expiration of that.
Thank you, Madam Chair. I really appreciate it. I know we're short on time. So you mentioned that this is only temporary, but it's my understanding that President Biden has asked that 600% be made permanent. And so if it did become permanent, or I guess since the conversation is being had, should we be spending time in the interim studying this and then bring this back as a whole picture and piece now that we know? And I understand the ARP stuff just hit April 1 with this aspect at least. And then bring this back next session so we have time to fully tweak it and get all the bugs out of it before we actually implement this.
Thank you for the question, Assemblyman. Nicole Cannizzaro, Senate District 6. I think the short answer is yes. Until there is something that says this is absolutely permanent, we're betting on conversations that would happen at the federal government and hoping that we're going to solve a problem with that. I also don't think that that solves the entirety of the problem, and I think complements very well with the actuarial study that would be conducted in accordance with the waivers that are sought in this particular piece, and is not going to cover all of the Nevadans who I think really would fall under the provisions of Senate Bill 420 if we are able to implement it.
And thank you, Mr. Hafen, and thank you for the courtesy and members. A question and a follow-up, and then we're going to go from there. I'm going to go to Ms. Tolles, and then I'll come over to Mr. Roberts afterwards.
Thank you so much, Chair. And my first is just first of all, good to see you. And first is just a quick question. I apologize if I missed it. How many Nevadans are currently eligible for Medicaid right now, but not taking advantage of it, that we're not capturing?
Thank you for the question, Assemblywoman Nicole Cannizzaro, Senate District 6. I would invite, I know we do have Ms. Weeks who can provide some technical assistance, and she may have that answer more readily at her fingertips than I do, but
yes, thank you. This is Stacey. Sorry. Madam Chair, committee members. Of the 350,000 uninsured, 37% are eligible for Medicaid.
Could you repeat your statement, please?
Oh, my apologies. I must be having some technology difficulties. Of the 350,000 people uninsured, about 37% are expected to be eligible for Medicaid.
Thank you. Follow-up, Chair, and I'll make it quick.
Right. 350,000 that are eligible to be on Medicare. 37% are currently enrolled.
Sorry. No, sorry, my apologies. There are 350,000 uninsured Nevadans, roughly. Of that 350,000 uninsured, according to the most recent information we have from the Clinton Policy Center, is 37% are expected to be eligible for Medicaid.
Thank you, and it's cracking up, so that's why I wanted to make sure I repeated it and got
I'm
a confirmation.
sorry.
No, that's quite all right. Technology is great until it isn't. So with that, Assemblywoman Tolles.
Yes, thank you. And so we didn't really go through each of the fiscal notes, but just looking at the fiscal note for DHHS, we're looking at roughly $75 million over the biennium. And I'm just wondering if it would be less expensive and make more sense to do outreach to that 37% to try and get them enrolled. My concern here is that we're going to have just one more option and they're still not going to be taking advantage of it. Thank you.
Thank you for the question, Assemblywoman Nicole Canizaro, Senate District 6. So I think two things. One, with respect to some of the DHHS provisions that you're seeing in the fiscal notes prior, a lot of those were related to, and I know I see Ms. Bierman on the Zoom, so she can correct me if I am wrong, were related to some of the Medicaid pieces for pre and postnatal care for pregnant and nursing moms. For this particular provision, I don't think so first I would note the public option, if you were eligible for Medicaid, then you would not qualify. Well, you could buy it off exchange if you wanted to buy the public option off exchange. But obviously, if you were eligible for Medicaid, we would seek to get you enrolled in Medicaid. Similar to when we've seen expansions of other healthcare provisions, individuals who end up being eligible for Medicaid typically are signed up for Medicaid because that's going to be the most affordable place for them to be. And so, of course, we want to make sure that we can help in any way, and I think the public option works in conjunction with those outreach efforts and the navigator programs that we've seen with the exchange to help get people enrolled on Medicaid when they do qualify. But there is still a significant portion of that population that is still uninsured or underinsured or can't qualify for subsidies on the exchange or don't qualify for Medicaid. And so they would still be individuals that we want to get covered, and the public option would be an avenue for that.
With that, I have Mr. Roberts next, and then I'll go to Dr. Titus. Please keep in mind our time. Mr. Roberts?
Thank you, Madam Chair, and thank you, Senator, for being here this morning. Good to see you again. So a question about the hospital rates. And under the public option, currently Medicaid and Medicare, I think Medicaid's in the 50 percentile for reimbursement, and it's almost 90 for Medicare, or I may have it backwards. But this bill proposes to move people from the commercial rate onto the Medicaid or Medicare rate. And so it's going to cut a lot of the reimbursements to hospitals. And we saw this last cycle, or when we restored some of the cuts for pediatrics, right? Because we were trying to solve an issue at Sunrise, and because they were ultimately going to cut services if we didn't do that. Do you think that this creates that scenario? Could hospitals potentially cut services because their reimbursement rates are going to be forced to be lower?
Thank you for the question, Assemblyman Nicole Canizaro, Senate District 6. So first, I want to clarify a couple of things about the public option. This does not require for everyone who is on commercial health insurance to take a Medicaid or Medicare rate. What the public option has in it is, as a floor, that the public option must at least be Medicare reimbursement rates. We didn't want to do Medicaid, obviously, because of some of the issues that I think you have outlined. And so we went with Medicare as a floor. This is not a ceiling. This is not a mandatory. This is what you would get in terms of reimbursement. Some of the concerns that we have heard is that, well, if you set a floor, then that's all there is. But frankly, I think that ignores the very essence of bidding on insurance products, even in the exchange, right? If somebody else has a different, is bidding on what it is that they would offer, you still have that negotiating power. The state is still going to utilize its negotiating power. Yes, we are trying to create something that will cost, from a premium standpoint, Nevadans less, but we're utilizing not only the state's own procurement authority, but also the public option health trust fund, which will allow for us to draw down some federal dollars to help buy down those premiums as well. And then, of course, the premium reduction over time. But I think that is one of the misnomers when you see the Medicare rates in there, that it is not mandating that that's what the rate would be. That's what it must at least be when we're talking about bidding on these particular plans. There's other provisions in the bill, of course, that these must be silver and gold plans, that we want to incentivize value-based systems where we can get people into care that can help to address issues before they become acute. acute. And one of the issues, I think the secondary issue that you raised, which is when we are talking about adding individuals onto health insurance, what does that do with respect to lowering rates for providers? Currently, the individuals and the small group employers that we're trying to get here, either one, are offering healthcare plans that aren't providing the kind of healthcare that is necessary for the individuals covered on those healthcare plans, or they're uninsured or underinsured. So when an individual who is uninsured goes into a hospital and receives care, it is often for a more acute injury or disease. It is often on an emergency type basis, and it is uncompensated for with respect to the providers. So when we are talking about what impact this would have, we are not talking about taking people from their employer plans. In fact, they wouldn't. All the provisions of the ACA still apply, and that's reflected in the language of the bill. So that's not who we're talking about. If somebody qualifies for Medicaid and they're on Medicaid, that's how they would receive their care. But for other individuals who are currently going to providers once something has become a much more distressing situation that involves much more medical care in order to address, that is currently uncompensated. And we're trying to get people onto health insurance programs that they can afford that will actually provide for compensation for that care.
Thank you for the question and answer.
Thank you. And with that, I'm going to go to Ms. Hodge, and then I'll go down to Dr. Titus. Ms. Hodge.
Thank you so much, Madam Chair. And my question is, it's piggybacking off of the question from Assemblymember Tolles. And if I did my math correctly, and this might be a better question for Medicaid Majority Leader, because they said that there's 350,000 people uninsured. 37% of them are eligible for Medicaid, and with the help of my phone, that's roughly about 130,000 people who are eligible. And my colleague asked the question about redirecting that money on the fiscal note to maybe these people, outreach to these people. If I could ask Medicaid how much it would cost them to reach out to these people, to get these 130,000 people enrolled, what would that cost be to do outreach to them?
Morning, Suzanne Bierman, the Administrator of Division of Healthcare Financing and Policy, for the record. Thank you for the question. I don't have that amount today, but would be happy to go back and see if we can put together an estimate. The Division of Welfare and Supportive Services does eligibility and enrollment, so we could work with them and see if we could put together a cost estimate for reaching the remaining uninsured, what outreach and education efforts might cost, and would be happy to do that. I did want to clarify that we have submitted an updated fiscal note. As the Senate Majority Leader mentioned, that prior number was based on an earlier version of the bill that didn't have the as funding allows language. So our new fiscal note is decreased significantly. So did want to clarify that for the record.
That was it for me, Madam Chair. Thank you.
Thank you very much, and I'll go to Dr. Titus next. And we do need to get to the fiscal notes. We are the Money Committee. So with that, Dr. Titus.
Thank you, Madam Chair. And I know we've been warned to keep this short, but I do have several questions. I'm going to start off with a question regarding access to care, and appreciate you, Senator, for I absolutely believe you want good health care for all Nevadans, and that is why you're bringing this bill forward. Yesterday, Becker's Health released a statement that the top 5 worst places to practice medicine are as follows: West Virginia, Louisiana, New Mexico, Nevada. Nevada's in the top 5 worst places to practice medicine. Do you feel in this bill you will increase access and bring providers to Nevada?
Thank you for the question, Assemblywoman Nicole Cannizzaro, Senate District 6. I think the answer is yes, and I know that there has been a lot of conversation about that this would lead to decreased provider access. Frankly, I think I struggle with that concept, because what we are trying to do is to include yet another piece of health coverage in order to ensure that when providers are seeing patients, right, that they are getting paid for that. I think that's an important piece of this, and that's something that I think gets overlooked. Some of the other I guess caveats to those kinds of statements are, well, we have the ARP stuff, or we should just put more people onto Medicaid. Yet at the same time, we often have the arguments that, Medicaid rates are too low here in the state, so why would providers want to have to take more Medicaid patients because then they start to lose money? I think it is inconsistent to say that we should just be putting more people onto Medicaid, or that somehow if an ARP temporary solution, which I know we had that conversation, is helpful in getting people onto coverage, and that's so great for providers. Why, if we are creating another option for people to have health coverage so that they are in fact also getting preventative care, regular checkups, and in this bill we've built in, obviously as part of the procurement, preferences for value-based services so people can get that kind of care, and made sure that what we have here are plans that are actually going to provide that kind of thing. That absolutely that should be an incentive for providers, because they're going to get compensated for having seen people, and they're going to be able to help with better health outcomes overall by being able to have people covered.
Great. Follow-up, Madam Chair?
And if I can, Dr. Titus, what was the study that you cited? It went by pretty quick.
Becker's Health.
Becker's Health? Okay, I just wanted to make sure.
And
that I
then
didn't
follow up
hear.
on that, you mentioned reimbursement. And so just to be clear, the reimbursement's not going to be based at the Medicaid reimbursement, it's going to be at the Medicare reimbursement.
Nicole Canizaro, Senate District 6. Assemblywoman, that's correct. That is what the minimum would have to be for the public option plan. So it could be higher than that. And obviously we want to encourage negotiations in those spaces, so we didn't put a ceiling on that, but it is Medicare.
And it's not cost-based, however.
It is not.
Great, because the Medicaid, of course, see, and I've said on this here many, many times for the many sessions I've been here that, just to be clear, Medicaid rates are horrible, Medicare rates are bad. So none of it's good, and we lose money no matter which one of those rates we negotiate. So thank you for that clarification. And then finally, is there anything in this bill with if the actuarial comes back bad, if Nevada is set to lose money, if this does not work, mandating that we follow it, what will be the state's option if this does not look good for the state of Nevada?
Thank you for the question, Assemblywoman. Nicole Canizaro, Senate District 6. I fundamentally believe that we are going to see a place where we are going to have an option that is going to help get people insured that's affordable for them. So I would start there. Second, we obviously have built in, after concerns that we heard over in the Senate, the requirement for the actuarial to take place, which we have to do in order also for some of the waivers that we are contemplating that will help buy down the cost of those products. But additionally, I would note that there are, built into the timeline of this bill, 2 legislative sessions. I don't think anybody here in this building is ever coming in here and saying, well, I would love to implement a horrible piece of legislation that is going to do no good for Nevadans. So I definitely think that there are opportunities to make improvements if we need to. And the whole purpose of this is to start getting it set up so that we can be ready for procurement, we can make adjustments as necessary, and that we will have data to help back that up.
Thank you for your work on this, and thank you, Madam Chair, for the questions.
You're welcome, Dr. Titus. So do I have any other questions from other committee members? I have Majority Leader, go ahead.
Thank you so
And then
much.
Mr. Levitt.
Thank you so much, Madam Chairwoman. And more than a question, I think it's just something that I want to make sure that we have on the record for food for thought. And it's to the reference of the definition of small employer in Section 10. And so I believe the way that we're referencing with the U.S. Code, this is the reference to saying a small employer is someone with less than 50 employees. And so I think what we have been doing in other programs throughout the state is kind of proposing that we talk about a small employer by their revenues and account for very healthy and for-profits that are doing very well and having the resources to supply things and cover cost of things like health insurance for their employees versus just a hard, fast quantitative number that at all doesn't reflect whether or not a company is highly profitable or not, right? So we have lots of tech companies like that. They might have 5 employees, but they might be doing $10 million a year. And so I just kind of want to put it out there that it might be interesting to say, what if we had, small employer defined by those who have to file and pay the commerce tax in Nevada. For example, we did that in the PETS program at the beginning of the year to say that if you want to be eligible for this kind of assistance, then you can't be a company that's grossing more than $4 million a year in revenue. And so we knew that in 2018, the tax department let us know that there were 388,000 small businesses, taxpayers, who did not qualify in terms of meeting the $4 million in gross revenue to have to pay the commerce tax. The actual bill that we passed said that if you come within, I think it was 500,000. So if you're close, you got to file just to make sure you can't pay it. But we would have 388,000 non-filers. So that was a great number because that kind of gave us a reference for how many businesses that are out there that don't gross more than $4 million a year. I have been one to say that if you are grossing more than $4 million a year and we start to line things up with that commerce tax reference, then we're talking about profitable companies. And what we want in this state is for profitable companies to insure their employees. We do not want highly profitable companies to be forcing their employees onto Medicaid, because that's the welfare conversation, or the Walmart, the Amazons, the Teslas, right? That's our big problem when you have very highly profitable companies who won't insure and who build their business models with part-time employees and won't insure them. And it's only been getting worse. So as much as we can, I think it would be interesting to consider that. I think it would be a great statement about making sure that when we talk about small businesses and we have a quantified number, we would want, close to 400,000 small businesses who don't make a lot of money to have an option for their employees to have health care in this way. I don't think what we would want, though, is, a little bit of that conversation where some folks are worrying about siphoning, where we have highly profitable companies pushing their employees to a system like this simply because they want to drive their margins up. That we have to fight. Thank you for your consideration.
Okay. When we make it a question, we just say correct at the end, and then the sponsor says yes. So that works out really well. So with that, I think I had Mr. Levitt next, and then I don't think there's any other questions, so then we'll go ahead and move into the other portions of testimony.
Thank you,
Mr.
Madam
Levitt.
Chair. I don't know if you're going to be able to say correct at the end of this or not, but we'll give it a try. So doing some research, so Washington currently has a public option, right? And their rates are actually fairly high compared to the non-public option. I think it's 29% is what we saw. And so very few people are taking the public option, 1,900 people taking the public option. So, when you have over 200,000 people that are eligible for it and only 1,900 are taking it, there's obviously a problem. So I thought, did you guys look at that? And so how does this plan differ from that plan? So we don't fall into that trap.
Sure. Nicole Canizaro, Senate District 6. So I will say, I think with the caveat that this is different than what exists in Washington. And I know Ms. Weeks may be able to hopefully have some good technological connections and be able to provide a little bit more context to that answer.
Go ahead.
Madam Chair, committee members, Stacey Weeks from Aurora Health Group. Thank you for the question. Washington is different. I would start with this bill has been trying, I think, to address many of the issues seen in Washington around the premium. And so the bill includes a premium target where at least plans have to come in at least 5% lower. That was not in Washington. There's also something I think very different in this bill than other public options that you may be hearing about and others have written about, and that is the purchasing strategy. This bill includes a procurement process that would be bid simultaneously with the Medicaid managed care plans. And by tying those two together, the state is able to basically leverage its purchasing power, which you don't typically see with the other public options that are currently out in the world of discussion. And with that, it's similar to a large employer who has a number of covered lives and money that health insurers are wanting to win the contract. They can leverage that. The other thing to note about Nevada is just that its uninsured rate is much higher than Washington. It's a different state. And so this bill in many ways addresses issues differently. Washington has a much lower uninsured rate. So I think it's just a different situation, and the senator's bill definitely does it in a
I
Correct.
believe we might have lost you for the last couple of sentences. But
Oh,
Mr. Levitt, did
I'm
you get most
sorry.
of the information that you needed? I think Mr. Levitt has the answer to the question that he posed. So thank you very much. We understand the technology.
Thank
So
you.
with that, any other members of the committee with a question at this time? Not seeing Mr. Levitt? Okay. Yeah, I did say you could have one. Make it short.
So, keeping that in mind to where you're adjusting the rates accordingly, and I would imagine I didn't work on the Washington plan, but I would imagine the rates were set that way in order to not lose providers. And so, is there a potential that we're going to lose providers because we're not adjusting those rates? Because I would imagine that that's why they did it, was because they didn't want to lose providers. So how are we balancing that out to not lose providers by managing rates the way it's laid out?
Nicole Canizaro, Senate District 6. So I think I will note a couple of things, and then I know we've been having some technical difficulties, and I apologize, Madam Chair, with Ms. Weeks. First, I would say that we are pairing this with actuarial data that will also look into the premiums and to look at what we're talking about in terms of reducing those over time with the 15% that you see in the bill. And so I think that that's a notable difference. And again, I think because these plans are different than what is occurring and what is happening in Washington, we're just in a very different space. And I don't know if Ms. Weeks had anything else that she wanted to add, but I wanted to note that piece about the actuarial.
Thank you.
Madam Chair, I have nothing to add.
Thank you very much. With that, I believe we probably need to get to the fiscal notes now, since that's kind of part of our responsibility here in this room. So with that, I believe the Medicaid fiscal notes were adjusted as the bill left the Senate, is my understanding. Ms. Kaufman, would you address the fiscal note from the Silver State Health Insurance Exchange, please?
Thank you, Madam Chair. For the record, Sarah Kaufman, Legislative Council Bureau. The Silver State Health Insurance Exchange testified in the Senate that there would be a $600,000 cost related to the waiver development as well as an actuarial assessment. And during that testimony, it was unclear whether or not they could utilize their reserves in order to pay for these expenditures. Upon the hearing, it was discussed with our fiscal staff that they would not be able to use their reserves to address this fiscal impact.
I understand correctly, when the bill left the Senate, it still was undetermined whether they could use their reserves, or had that actually been put on the record then? Majority Leader?
Thank you, Madam Chair. Nicole Canizaro, Senate District 6. My recollection is, I think as Ms. Kaufman stated, that we had a conversation about it in the Senate, that there was an indication that they may be able to use their reserves. That question had not, I think, been 100% decided, but when we left the Senate, we did not allocate that $600,000 for that.
Okay, thank you. So I guess I need to have the Silver State Health Insurance Exchange. Are they available? Do we have someone?
Good morning. Yeah.
Good morning. If you could address that, please.
Good morning. This is Jennifer Krepp for the record. I'm the financial officer for the Silver State Exchange. When this bill was heard in the Senate Finance Committee on Friday, May 21st, it was asked if we would be able to use our reserves to cover this, to cover the $600,000 in actuarial and waiver development costs that are projected in SFY 2023. The carrier premium fee that the exchange collects is our only source of revenue, and this carrier premium fee is governed by the Affordable Care Act, specifically Title 42 of U.S. Code Section 18031, Paragraph 5A and B, which indicates the funding limitations. Paragraph A indicates that exchanges are to be self-sufficient, and they may become self-sufficient and not use federal funds by the imposition of a fee upon carriers who sell on the exchange marketplace. Paragraph B indicates that, among other things, that these user fees cannot be used for state or for state legislative or regulatory programs. So we cannot use this for state programs such as this.
And you didn't realize that with the bill being in the Senate for the amount of time that it was there?
I indicated that we needed to conduct some additional research. So additional research had been conducted, and our fiscal note has been updated to reflect that.
Okay, thank you very much. So that would mean, Majority Leader, that a general fund appropriation would be needed in order to be able to do that?
Thank you, Madam Chair. I believe that is correct. Nicole Canizaro, Senate District 6.
Okay, and those are, and those dollars, and we're going to talk fiscal talk here for just a second. So those dollars were not put on the sheets before it left the Senate. So those dollars will be on the sheets on the Assembly side.
Thank you for that, Madam Chair. Nicole Canizaro, Senate District 6. It was not put on the sheets on the Senate side. The allocation that is included, or the appropriation rather, that is included in the bill was for the other pieces for Division of Welfare and Supportive Services and DHHS.
Okay, we just want to make sure we have a complete record as we move forward, as we have to be able to figure out how to fund everything. So with that, I think that addresses that issue. So that's something we're going to have to work on also. So with that, I believe we're good there. As I said, we were going to open it up for support, opposition, and neutral. I'd like to keep everyone to 2 minutes. If the person before you said ditto, that allows more people. So we are just at a couple of minutes past 10 o'clock. So with that, I will go to support in the room, and in order to try to be fair, I'll do a couple in the room, couple on Zoom, couple on phone, and go around that way so that the room doesn't take up the whole time. It would not be fair to the other folks. So with that, Majority Leader, thank you very much. We appreciate it. There are 2 seats at the table. Those in support, please. And we're starting support at 10:02.
Madam Chair, Chris Daly, Nevada State Education Association, and NSEA supports SB 420, creating the Nevada Public Option. Like education, Nevada ranks near the bottom in states in investment in health care. In addition to underinvestment, health disparities continue to run deep, with low-income communities facing fewer options and higher prices, and significant health disparity in Nevada's communities of color. In Nevada's rural communities, there are even fewer health insurance options, with typically just one plan on the exchange or none at all. In order to access basic health care in rural areas, many Nevadans have to travel hours. In some emergency situations, air transport is required at a very high cost. Due to WEP GPO, many retired Nevada teachers face barriers with Medicare and instead rely on private insurance plans. Some of these carriers have been known to push older Nevadans into plans with high deductibles and copays. The public option created by SB 420 will ensure that Nevadans always have equal access to affordable quality coverage. We hope you support the bill. Thank you.
Thank you, Chair and members of the committee. My name is Tess Opferman, speaking on behalf of SEIU Local 1107 and the Nevada Women's Lobby. SEIU Local 1107 represents hospital workers across Nevada, including more than 9,000 nurses and ancillary professionals across Nevada who serve on the front lines caring for the uninsured. Our members see firsthand that the vast majority of these patients are suffering from conditions that could be treated earlier if they had access to quality health insurance plan and preventative care. All Nevadans deserve the opportunity to be covered by quality, affordable health care, and it is up to our state legislature to pass policies that ensure they have access. SB 420 is an important measure to help protect Nevadans. SEIU Local 1107 and the Nevada Women's Lobby are in full support of this measure, and we thank you for your time this morning.
Good morning, Madam Chair and members of the committee. My name is Sarah Adler with Silver State Government Relations, representing the Nevada Advanced Practice Nurses Association. So NAPNA is in full support of SB 420 in two pieces. To the public option piece, Nevada obviously needs affordable health care, and APRNs, or nurse practitioners, as fully licensed, accountable, and qualified primary care providers will be a great provider source for public option plans. APRNs are often receiving horrible reimbursement rates now, and they would be glad to go to bad reimbursement rates under public option plans. And then the second piece that NAPNA supports is the Medicaid Enhancements. Many APRNs specialize in obstetric and pediatric care. The focus of the Medicaid Enhancements in 420 as well, they very much support Section 27, which will provide reimbursement parity for APRNs should funds be available. California, Oregon, and Washington all provide reimbursement parity for APRNs. We in Nevada are going to have a hard time retaining our nurse practitioners and attracting more of them if we do not meet our surrounding states in reimbursement parity. Thank you very much.
Thank you, and I'm going to go to Zoom. Is there anyone in support on the Zoom link at this time? Not seeing anyone. I'm going to go to the phone lines. Is there anyone in support on the phone lines for SB 420?
If you would like to testify in support on SB 420, please press star 9 now to take your place in the queue. Caller with the last 3 digits, 831. Please slowly state and spell your name for the record. You will have 2 minutes and may begin.
Hi, committee members. My name is Maria Nieto Orta, M-A-R-I-A, last name N-I-E-T-O, space O-R-T-A. Mi familia votas in strong support of SB 420. It is a very much needed investment for our community. Mi familia vota submitted written testimony to further expand on the need of SB 420. We urge the support of SB 420, and thank you for your time.
Thank you. Next caller, please.
Caller with the last 3 digits, 084. Please slowly state and spell your name for the record. You will have 2 minutes and may begin.
Good morning, Chairwoman Carlton and members of the committee. For the record, my name is Tom, T-O-M, Wellman, W-E-L-L-M-A-N, and I'm a resident of Assembly Senate District 1. I have successfully retired from the Clark County School District and am currently serving as president of the Nevada State Education Association Retired Program. I'm submitting these remarks in support of SB 420. One of the major expenses that all senior citizens and our members face in retirement is the continuing and escalating cost of health care. Retirees that live in rural Nevada also face the additional burden of accessibility to quality, affordable health care that does not require them to drive over 2 hours or more to see a doctor or go to a hospital. Any measure that can be put in place to help curb this runaway train is greatly appreciated. SB 420 is that measure. NSCAR is asking that along with everything else you're faced with, you make access to retiree health care a priority and also address the escalating cost of prescription medication. However, please keep in mind that Nevada is a weapon GPO state, and many of our retired members may not qualify for access to either Social Security or Medicare. Please consider as you move forward that active educators will also need to have access to quality, affordable health care when they retire. Working together, we can help to solve this problem for the employees that continue to handle these life-changing assignments on a daily basis. We support SB 420. Thank you.
Next person on the phone line, please.
Caller with the last three digits, 035. Please slowly state and spell your name for the record. You will have 2 minutes and may begin.
Thank you so much. For the record, my name is Quentin Savoy, QUENTIN SAVWOIR. I'm the Deputy Director with Make It Work Nevada. In the interest of time and at the instruction of the chair, I just want to say ditto that we support SB 420. This bill will be great for Nevadans in ensuring that we have healthy futures. Thank you so much.
Thank you, Mr. Savoy. You have a future in testimony. Thank you very much. I'm going to come back to the room, so please proceed.
Good morning, Chair and members of the committee. For the record, my name is Christine Saunders, and I'm the Policy Director with the Progressive Leadership Alliance of Nevada, here in support of Senate Bill 420. This morning, I actually want to share a very brief personal story with you. I just recently celebrated my 5th wedding anniversary. While I had been with my partner for many years prior to getting married, the date of our wedding was rushed. It was quickly scheduled at the courthouse 12 days after my 26th birthday, the day I was no longer covered by my mother's health plan. I will note, I told my husband if I was injured in those 12 days I was uninsured, he was paying for it. A policy like a Nevada public option would have made a huge difference when I was struggling to ensure that I was still going to have access to my medical care for chronic illness and to the prescriptions I take every day. And in fact, it probably would have been more affordable coverage for both my husband and I than utilizing his employer's high deductible health insurance plan. On behalf of Plan and myself, I urge that you support this legislation. Thank you.
Proceed.
Good morning, and thank you, Chair Carlton and members of the committee. For the record, my name is Benjamin Challoner, and I'm the Policy Director for Faith in Action Nevada. We are here in strong support for Senate Bill 420. Loving your neighbor and healing the sick are major priorities of the faith communities that make up Faith in Action Nevada. It is our moral obligation to be able to provide affordable and accessible healthcare to all. By providing a public option that all Nevadans can buy into, we are ensuring that they get the healthcare coverage that they need. SB 420 will allow for increased access, mobility, and foster equity in healthcare. We urge your support. Thank you.
Proceed.
Good afternoon, Chair and committee members. My name is Amy Koo, the Deputy Political Director with One API in Nevada. Nevada is home to over 300,000 Asian Pacific Islander Americans, comprising about 10% of the total population, and we are the fastest growing community here in the state. We have submitted a written testimony, and we also have community members who will be submitting op-eds in different newspapers throughout the week, including Asian Journal and the Philippine Times. We urge you to review those and support SB 420. Thank you so much.
Proceed.
Thank you, Madam Chair. For the record, my name is Annette Magnus, and I'm the Executive Director of Battleborn Progress. We thank Senate Majority Leader Canizaro for her leadership on this bill, and we support SB 420. I'm going to skip to the part where it matters. I want to add that technically, we are a small business. I pay 100% of our 10 employees' health insurance and their children. We pay over $6,000 for health insurance a month. That does not always cover everything we need with the best plan available by Sierra Health and Life. I cannot wait for this plan to be available to us so we can have better, more affordable options and coverage for our employees. I urge you, please support this bill. Thank you.
I'm not seeing anyone on Zoom. I'm going to go back to the phone lines. Anyone in support on the phone, please?
Caller with the last three digits, 169. Please slowly state and spell your name for the record. You will have 2 minutes and may begin.
Good afternoon, Chair and committee members. For the record, my name is Jennifer Fleischman, Jennifer, Fleischman, FLEISCHMANN. I am the co-director of organizing at Make the Road Nevada, and I'm here today in strong support of SB 420. As a woman with factor V Leiden thrombophilia, it would have cost me over $10,000 in prescriptions alone to have my pregnancy in Nevada. In the interest of time, I won't go into details, but I did submit written testimony that I hope you will review. I am in strong support of SB 420, as is Make the Road Nevada, and I hope that you will join us in that support. Thank you.
And thank you for supporting written testimony in addition to your testimony today. Broadcast Services, next caller.
Caller with the last three digits, 346. Please slowly state and spell your name for the record. You will have 2 minutes and may begin.
Thank you for your time this morning, Chair and committee members. For the record, my name is Reverend Michael Willoughby. Today, I am speaking in my personal capacity. That's WILLOUGHBY MICHAEL. I'm here today to speak in support of SB 420. And while I'd normally be here to give voice to your conscience, today I'm here to give voice to my best friend, Ian Wilkinson. I'm speaking on his behalf today because he can't be here. After 28 years of love and friendship, after he beat what should have been fatal lymphoma, I lost my best friend last December. Ian died because he lost his employer-sponsored health insurance and couldn't afford to get basic medical treatment. He died by himself on the floor of an Eagles Hall. None of his friends had a chance to say goodbye. None of his family had a chance to say goodbye. And sadly, Ian's story isn't unique or even rare. We are failing Nevadans every day, and it's time to do something. It's time to do something about the pain that I get to carry every day being duplicated ad nauseum over and over again. And so I'm here to plead with you to exercise your power, not for me, but for Ian and for every other Ian out there and friends and family that get left behind when this stuff happens. It could be you next. It could be anyone in this room. Please let something good come out of the death of my best friend, Ian Wilkinson. Please support SB 420. I've also sent in this testimony for review as well. Thank you, Chair.
Thank you. Next person in support on the phone line.
Caller with the last three digits, 338. Please slowly state and spell your name for the record. You will have 2 minutes and may begin. Caller 338, please press *6. Oh, pardon me, you're unmuted on our end. Caller 338, please press *6 to unmute. You were unmuted on our end. I'm not sure if your phone was unmuted. We're going to try that one more time there, Chair. There you are, caller.
Good morning, Madam. Good morning, Madam Chair. I apologize. Members of the committee, Priscilla Maloney, Priscilla Maloney, representing the AFSCME retiree chapter this morning. We did submit written remarks on May 4th to the Senate Committee on Health and Human Services, but just to reiterate, SB 420 will capture a portion of the 350,000 uninsured in Nevada that Mr. Daly and the NSEA retirees just referenced. These are folks who are by virtue of their age, and non-Medicare for other reasons, retirees. I would like to make one important point to the committee, and this is in reference to a question that Assemblywoman Tolles raised. It's important to understand that when we talk about moving people to Medicaid, that you cannot toggle between Medicaid and Medicare. And many folks who are entitled to Medicare but lose their job and thus their employer provided health care late in their careers, they do not want to be forced onto Medicaid. They want to preserve that right to be in Medicare once they age into that system. So SB 420 would meet an important gap for those folks in that part of this population that we're globally talking about today. So thank you, Chair Carlton, for the time.
All right, with that, do we have anyone else in support on the phone line?
Caller with the last three digits, 362. Please slowly state and spell your name for the record. You will have 2 minutes and may begin.
Thank you, Madam Chair. My name is Katie Robbins, Katie Robbins, and I am here on behalf of Planned Parenthood Votes Nevada. I'll say ditto to what we have already heard. Increasing access to health care, including reproductive health care, will make our state stronger and more equitable. Thank you for your time, and we urge the committee's support of SB 420. Thank you.
Thank you very much. I'm going to come back to the room. Is there anyone else in the room in support at this time? Not seeing anyone else in the room in support or on Zoom, I'll go ahead and do a couple more on the phone line with our technical slowdown. I'll give them an opportunity. Anyone else in support on the phone line?
Caller with the last three digits, 689. Please slowly state and spell your name for the record. You will have 2 minutes and may begin. Caller 689, you are unmuted on our end. Is it possible your phone is on mute?
Oh, good morning, Chair and committee. Thank you for your time. For the record, my name is Anwar Green. That is A-N-W-A-R. Last name is Green, like the color, G-R-E-E-N. I'm here to express my support of Senate Bill 420, as I believe a public option benefits all of us. As someone who just recently obtained insurance through my employer, I'm way too familiar with the uncertainty of being uninsured and having to make a choice between a doctor's appointment and a necessary bill. And while some will look at my situation and say that's unacceptable treatment for a veteran, I believe it's unacceptable for anyone, especially in Nevada, to be unable to see a doctor because they're uninsured, and for anyone to be uninsured because they can't afford it. And as I'm sure you all know, studies continue to show that people support this legislation in a growing majority. And for those reasons, I support Senate Bill 420. I thank Senator Canizaro for bringing this legislation, and I thank you all for your time. Please pass this bill.
Thank you very much. And with that, if there is anyone else on the phone lines in support, we would ask you to submit your comments in writing, please. We're going to go ahead and open it up for opposition. It is 10:20. We're going to do about the same process. So I'll go to folks here in the room. Please keep the 2 minutes in the back of your mind. Mr. Wadhams.
Thank you, Madam Chair. Members of the committee, my name is Jim Wadhams, W-A-D-H-A-M-S, here today representing the Nevada Hospital Association. Hospital Association, of course, supports access to care. In fact, hospital facilities with emergency rooms are open to all comers, irrespective of any condition of insurance or otherwise. So access to care is important, and I think, having listened to the testimony today, and I compliment Senator Canizaro and her advocacy, I think it's very important that this committee in particular, that is charged with the fiscal impact, analyze the contingencies and the uncertainties that are represented by this bill that are so important. In that regard, and specifically, I want to draw the committee's attention to the purposes of the bill as stated in Section 2. It is designed to improve access. It is designed to reduce disparities in access and designed to increase competition. That's Section 2. One of the problems we have, members of the committee, is that has to be based upon data. We can't assess whether this is going to improve something that we haven't previously measured. We know we are 45th in the country in terms of physicians per capita, approximately 45th, maybe 48th in terms of nurses per capita. And this hospital association has just gone through a pandemic in which many of you saw in your communities, both north and south, a tremendous expansion of the capacity in order to accommodate the significant impact of COVID patients, from converting garages to putting up tents in Las Vegas and retooling the Convention and Visitors Authority facility to be prepared to handle that. So this is an industry that is prepared to deal with people who come and who have needs. The concern, of course, though, becomes the cost. And looking at page 25 of the SCR-10 Manat study, they specifically indicated that study did not address the risk modeling. That is, what is the cost of this? There are certain contingencies built into the proposal, including applying for federal waivers, federal grants, all of which, as this committee especially knows, uncertainty raises issues of cost. So perhaps the fiscal note should be evaluated in terms of set-asides to anticipate variations of whether those waivers are granted by the federal government. I think the other element that's really critical, because I emphasize the access in the purpose section, it would be critical that the state benchmark the current accessibility of care so that we could measure any improvements or deteriorations. I think it's especially noteworthy that the drafters of the bill paid particular attention to this issue in Section 13, subsection 2, where they exempted the mandatory participation if it is determined to diminish the access for Medicaid recipients and PEB beneficiaries. Why would that be the case? If you lose physicians, you will decrease access. And as hospitals, we can't go anywhere. We're bricks and mortar. What we need are the personnel, the doctors and the nurses. And if we lose that ability to respond to that because they're withdrawing from these other programs, that's going to decrease access And I think that is a measurement that needs to be monitored very, very carefully. We strongly suggest that the committee consider taking the first step on this laudatory goal of universal access, but do it in the incremental steps that show we have set aside the money to accommodate it, and we have assessed the measuring tools to accumulate the data to address it. With that, I appreciate the committee's time this morning. Thank you.
Thank you, Madam Chair and members of the committee. For the record, Trey Abney here today on America's Health Insurance Plans, otherwise known as AHIP, here to testify in strong opposition to SB 420. I was going to open and provide context and talk about the American Rescue Plan, but Mr. Hafen and Mrs. Tolles stole my thunder on that. But suffice it to say, the American Rescue Plan means that approximately 80,000 uninsured Nevadans now qualify for zero cost or significantly reduced plans through Nevada Health Link, and an additional 50,000 qualifying for reduced price plans. Also, 41,000 uninsured Nevadans will now qualify for premium tax credits who have never been eligible for subsidies before, and we've already mentioned the 37% of uninsured Nevadans who qualify for Medicaid now but are not on it. However, SB 420 would destabilize the Nevada healthcare system, and to Dr. Titus's point, by requiring providers to accept reimbursements at lower than cost. This would force these providers, in a state already experiencing a severe provider shortage, to recoup their costs by demanding higher reimbursement rates from all group plans, including small business plans. Moreover, this bill does nothing to address the underlying cost drivers that are driving higher premiums. Other than setting arbitrary rates for providers and hospitals, there is no mechanism included in the proposal to actually drive down the healthcare cost to achieve the bill's premium reduction goals. In particular, we should discuss the ever-increasing price of prescription drugs. Prescription drugs represent the largest portion of healthcare spending, making up more than 21 cents for every premium dollar. SB 420 demands that the public option premium achieve 5% reduction in premiums, but does nothing to actually address the portion of premium that keeps increasing, the high price of drugs. And Madam Chair, in closing, we urge you to focus on getting those in Nevada without coverage covered without driving up the cost of coverage for everyone else. We believe that this bill is step Z before we've taken steps A through Y, which were discussed earlier. And finally, Madam Chair, we do AHIP strongly supports expanding Medicaid coverage, and so we do urge you to move forward with those provisions of the bill. Thank you for your time.
Thank you. Next, proceed.
Good morning, Madam Chair and members of the committee. My name is Jaron Hildebrand, and I am the Executive Director of the Nevada State Medical Association. And on behalf of the American Medical Association and our physicians and med students, as well as the NSMA and our over 2,000 members statewide, we express our concerns today with the legislation we have before us. Our organization shares your interest in improving access to care, the affordability of health insurance. Covering uninsured and improving health affordability has been a longstanding goal of the American Medical Association as well as our state association. First, under the sections with the legislation, the physician participation of Medicaid, workers' comp, PEBs, we would require to participate in networks of this public option to accept new public option patients in the same manner as they would accept any new patients under the program. NSMA supports physicians' freedom of choice when it comes to health plan participation, and therefore we oppose this effort. Participation in a public option by tying it to participation of these three important programs. This mandatory participation provision overlooks the complexities of running a physician practice, the balance of determining the capacity of the ability of a practice to serve their patient mix. There are many reasons as to why practices will not participate with plans, including low reimbursement levels, burdensome administrative policies, saturation of practice resources, and physician time, the engagement in alternative payment models pending retirement, and so on. It is critical that a physician should be able to weigh in on their contract options and make decisions what's best for their patients and their practices. Secondly, we have concerns with the general established provider payment of using Medicare rates as the floor. While we appreciate Medicare rates meant to serve as a starting point, the targets for the negotiation between a provider, plans, and many physicians rightfully fear that these rates will ultimately become the de facto ceiling. This scenario is even more likely in returning requirements on participation remain in place and contract negotiations not required. Moreover, as a plan, we worked As plans work to meet premium saving requirements outlined in SB 40, it is highly unlikely that they will offer rates above the statutory minimum. Given the financial risks of setting a public option rate at Medicare baselines for physician practices, NSMA urges this body to consider the impact of the policy of the long-term sustainability of our small practices. Ultimately, access to care in Nevada, as such, we respectively ask this legislature to refrain from using Medicare rates as the floor for physician payments under this issue. We do feel that this would cause access to care issues and also network adequacy issues, especially with the mandate when you look at other states where their starting reimbursement rates are at 160% above Medicare without physician mandates. One, this bill is not means tested. We just heard on the record that some folks are looking forward to the bill this passed, so whoever already have commercial insurance would hop off those and move to this. This public option should be for those folks that make just enough above Medicare and Medicaid and are in those coverage gaps that can't afford a plan on the exchange. And we feel without that means test, this bill will likely cost shifting deductibles and increased premiums like we just saw in Washington, who already had to amend the bill after 5 months. Thank you.
I'm going to go to the phone line now, so Mr. Clark, if you would just be in a holding pattern, no one on Zoom. Those in opposition on the phone line, please.
If you would like to testify in opposition to SB 420, please press star 9 now to take your place in the queue. Caller with the last 3 digits, 261, please slowly state and spell your name for the record. You will have 2 minutes and may begin.
Thank you, Madam Chairman, and the rest of the committee. I really appreciate your taking phone calls. And I'm just an ordinary citizen. And when I listened to this bill,
if you could state your name for the record, please. If you could state your name for the record, thank you.
Bill Herrenberg. Yes, ma'am. Bill, last name Herrenberg, H-A-R-E-N-B-U-R-G. And again, I'm just an ordinary citizen. Thank you for all representing me. I'm really impressed by all the knowledge and wisdom that's in the room there and all the research that you've done. My immediate reaction is that this bill is just too risky for Nevada. It's the chances of us overflowing and requiring more money just is too much. If you look at the federal government, at least they can write checks and print money, but Nevada can't do that. And so those are my comments. Thank you, and I strongly oppose this bill.
Next caller, please.
Caller with the last 3 digits, 020, please slowly state and spell your name for the record. You will have 2 minutes and may begin.
Good morning, Chair Carlton. Mary Beth Sewald, S-E-W-A-L-D. I'm President and CEO of the Vegas Chamber. While I compliment Leader Canizaro on her advocacy, and we at the Vegas Chamber do agree that everyone should be able to access health care, we are opposed to SB 420. This bill would not reduce health care costs. Rather, it would shift costs onto other Nevadans. Also, mandating a state insurance plan to offer a rate 5% lower than commercial rates is another cost shift. Evidence from other states that have implemented similar programs confirms that insurance costs did go up, which is also very concerning to us. We agree that a thorough actuarial analysis to understand the full financial impact that SB 420 would have on the state and healthcare sector would be very helpful. There are also concerns about requiring healthcare providers to accept government-set reimbursement rates as well. And the impact that it will have on doctors is a concern to us. Thank you so much, Chair Carlton and committee members. I appreciate your time, and we urge you not to pass SB 420.
Next caller, please.
Caller with the last 3 digits, 114. Please slowly state and spell your name for the record. You have 2 minutes and may begin.
Thank you. Greetings, Chair, members of the committee. Amber Stidham, that's S-T-I-D-H-A-M, for the Henderson Chamber of Commerce. I'll be brief. We, too, continue to be extremely concerned about the impact to all Nevadans as a result of this proposal. We believe it's an unproven, costly government program will shift costs onto Nevadans with private and employer-provided health insurance, making healthcare more expensive and having the potential to dissuade doctors from accepting new patients on Medicaid and Medicare, thereby reducing healthcare access and choice to all Nevadans. It's for these reasons and those outlined by my chamber colleague just earlier that we too are strongly opposed and urge your opposition as well. Thank you.
Thank you. I'm going to go ahead and come back to the room. Mr. Clark?
Thank you, Madam Chair. Members of the committee, my name is Tom Clark. I'm here on behalf of the Nevada Association of Health Plans. I come before you in opposition to the public option provisions that are outlined in Senate Bill 420. The financial burden that it's going to place on Nevadans and the instability in the healthcare market it could place on our state. You've heard references to the Minot study. To be clear, that was a report that was put forth, an initial analysis of public option plans. That report states clearly, Nevada policymakers must consider the extent to which the model will have the larger impact on affordability for Nevadans, weighed against implementation feasibility, cost to the state, and impacts on existing markets, end quote. An actuarial analysis has not been completed on the concept before you today. While there is a study currently referenced in the bill specific to the waiver, there's nothing that requires the results of the actuarial analysis be submitted for review by the governor or by the legislature before moving forward with this public option. In other words, that the bill does not stop enactment of a public option pending the result of that study. Our recommendation is that the legislative action should not be taken until the results of that study are reviewed and put forward. And also, before considering and putting anything in NRS, we strongly suggest the state perform an actuarial analysis examining the impact on insurance market stability, network adequacy of healthcare providers, and potential cost drivers that could unintentionally impact consumers throughout our state. Private insurance managed care organizations must demonstrate that the insurance products they offer are actuarially sound. Shouldn't the state expect the same from a public option? We firmly believe so. Thank you, Madam Chair.
Please proceed.
Thank you, Chair Carlton and members of the committee. Lindsay Knox with McDonald Carano, representing the Nevada Self-Insurers Association. The workers' compensation community already struggles to impanel adequate choices of qualified physicians in all areas of healthcare. Many physicians already choose not to accept workers' compensation patients because of the regulatory requirements involved and the burden it places not only on themselves but also on their administrative staff. There are many injuries and industrial-related conditions that require specialized care with few to no appropriate physicians available to treat them. This issue is not limited to rural areas, but exists statewide, even in our largest counties. While NSIA fully supports the desire to increase access to health care for Nevadans, we believe that SB 420 will create additional detriment against workers' compensation stakeholders, including injured employees and our state and communities. In 2019, NSIA worked with the Nevada Justice Association to pass SB 381, created to expand each injured worker's access to quality health care. We believe this change will undermine the changes made under SB 381. Physicians who do not have the staff, desire, or resources to treat both workers' compensation and the public option patients will simply choose to withdraw from the state of Nevada's list of approved treating physicians and chiropractors for workers' compensation. This will cause a reduction in the limited numbers of physicians already available to our workers' compensation community. We therefore respectfully request that you remove workers' compensation physicians from the public option requirements. Thank you.
Thank you. Please proceed.
Thank you, Chair Carlton, members of the Ways and Means Committee. Maggie O'Flaherty with McDonald Carano for the record this morning on behalf of the Nevada Orthopedic Society, REMSA, and the Nevada State Society of Anesthesiologists. I won't be duplicative, but I just wanted to echo the remarks made by Mr. Hildebrand with the Nevada State Medical Association. Thank you.
Thank you very much. We've gone over just a bit, but I'm going to go ahead and do a couple more for the time lag in between. So is there anyone in opposition on broadcast services on the phone?
For those of you that just joined the call, if you would like to testify in opposition to SB 420, please press star 9 now to take your place in the queue. Caller with the last 3 digits, 859, please slowly state and spell your name for the record. You have 2 minutes and may begin.
Good morning, Madam Chair, members of the committee. My name is Janine Hansen, State Chairman of the Independent American Party. SB 420 will cost taxpayers, those with private insurance and those who pay cash for their care because they don't have health insurance, much more than any fiscal notes listed on the bill. Obamacare caused health insurance premiums for average people to double between 2013 and 17. This bill will ask more doctors to treat more people at below cost undermining care for everyone and forcing those who have private insurance or pay out of their own pocket to subsidize those who are on Medicaid or who receive the so-called public option. That means that essentially we are creating a hidden tax, that of financing Medicare patients and patients covered under the public option whose health care will now be subsidized by those who have private insurance, causing their insurance rates to go up, or those who don't have insurance, causing their cash costs for medical care to go up. I live in Elko County. Already it is difficult to find a doctor or get specialized treatment at the hospital. Everyone I know in Elko has to go out of town to Twin Falls, Idaho, 2.5 hours, Salt Lake, 3.5 hours, or Reno, 4.5 hours to see the doctor or go to the hospital. SB 452 will make access to health care in rural areas worse. Medicaid reimburses at only 52% and Medicare at 80% of actual costs. This makes it much more difficult to find a doctor who will take Medicaid or Medicare patients in rural counties or in a hospital that can't afford to stay open. Who can continue to treat patients at below cost? So that means there will be fewer doctors or hospitals, and especially in the rural counties. As Ronald Reagan said, government is not the solution to our problem. Government is the problem. The solution is simple. Freedom is the solution. Freedom from government regulations and laws regarding health care, freedom for insurance companies to truly compete, freedom of choice.
Ms.
of
Hanson,
healthcare
I would
so
like
that
you to wrap
we
up,
can
please.
choose.
Thank you.
That's my last sentence. Freedom is the answer to better health care, not SB 420.
We'll take one more caller in opposition, and then I do need to move to neutral. Broadcast services, any other callers?
Caller with the last three digits, 373. Please slowly state and spell your name for the record. You will have 2 minutes and may begin.
Hey, good morning. My name is Bob Russo. That is Bobrusso, and I oppose Senate Bill 420. Unfortunately, history shows that once the government gets involved with health care, something they have no business being involved with, the quality of care diminishes. Doctors are forced to treat people below cost, and medical decisions often shift from the patient and doctor to bureaucrats who run the programs. They decide if you are eligible for certain tests and treatments. No thanks. I do not want some state bureaucrat deciding my medical fate. Secondly, government-run health care programs are money sinks. Treatment quality is poor while costs skyrocket. It is estimated that the public option health insurance program will cost Nevadans $77 million in its first 2 years and nearly $200 million in the following 2 years, and costs will continue to rise. What percentage of our state's budget will be gobbled up by this wasteful program? In 2010 in Ontario, Canada, government-run healthcare took up 46% of their budget. By 2030, that number is projected to be 80%. Not much money left for anything else. As the Nevada Families for Freedom explained, this bill will ask more doctors to treat people below cost, undermining care for everyone and forcing those who have insurance or pay out of pocket to subsidize those who are on Medicaid or receive the public option. This bill, if passed, will fail miserably for the citizens of Nevada. So let us save ourselves a headache and high costs and oppose it now. Thank you very much.
Thank you very much, and that's going to be our last caller in opposition. It is 10:43, and we started opposition at 10:20. So with that, I'll go to neutral testimony. Is there anyone in neutral in the room? Doesn't seem like a neutral kind of bill. So with that, there's no one on Zoom. I'm going to go to neutral on the phone line, please.
If you would like to testify in neutral on SB 420, please press star 9 now to take your place in the queue. Caller with the last three digits, 018, please slowly state and spell your name for the record. You will have 2 minutes and may begin.
Madam Chair, this is Jim Sullivan from the Culinary Union. I was having some technical difficulties earlier, and I wasn't able to get through on the support side. Could I please give a support statement here?
If you would just like do 2 sentences and then send a letter in, that would be fair to everyone that's been on the line in the queue. So just give us a couple sentences and then send a statement in, okay?
Absolutely. We are in support of this bill for all the reasons that people in the support section brought forth. We agree with them on that. And I would also like to thank the majority leader for working with us to alleviate the concerns we originally had on this bill. Thank you.
And thank you,
I will
Mr.
submit
Sullivan.
more written comment later.
Thank you. Please submit the rest of your comments in written form, and we'll be sure to include them in the support section of the bill. We understand technical difficulties. With that, is there anyone else in neutral on the phone line?
Chair, that was the last caller in neutral.
With that, I'm going to go ahead and invite the majority leader back if she has any closing comments. And then committee members, we do have some budget bills to work through this morning also. I think the governor might be upset with me if I don't get the budget bills done, so.
Thank you, Madam Chair and members of the committee for your time this morning. Very gracious grant of time. I will keep it short so that budget bills can get moving. I just wanted to make a couple of points because it's some of the same points that we have heard about why this is not a good option. And I just want to preface that with, we live in a state where we have a perpetually high uninsured rate, an uninsured rate that has remained untouched with the expansion of Medicaid here in the state, and an uninsured rate that has been persistently right around that 11%, despite the fact that we have enacted provisions of the ACA and have plans on the state health exchange. For me, so much of what is voiced as opposition, I think, is addressed in a couple of factions. First, to ignore the fact that we are going to do an actuarial analysis and that is required as part of the waivers that we are seeking to get, I think ignores that is going to provide us with some data that if we needed to make adjustments such that this was not going to get at those individuals that we are attempting to get at in those small groups, then we can make those adjustments. I think this body is plenty smart enough to be able to do that with 2 intervening legislative sessions and with being able to take a look at it. But simply saying that we should just continue to keep studying this, and I know I'm in this point in the Senate as well, when there have been studies prior to my entering this building in 2017. There were bills proposed to solve those solutions, or excuse me, to solve those problems. Those bills were vetoed, and we were asked to look at it again. That happened yet again. Then last session, the concept was brought forward, and they said, well, we should study it again. So we have data. We know where there are people who are uninsured, and frankly, I think that is even supported by the fact that we are seeing the federal government come in and give some money in order for people to be able to afford health insurance. The idea that that is okay and that we should still oppose something like 420, which is seeking to utilize federal dollars to do the same thing to get people insured, to me doesn't make any sense. The idea that we should just expand Medicaid as the only option when we continually hear how much that is a burden for providers, for hospitals, and then the argument that accompanies 420 is that this is going to cost the state a significant amount of money. I would venture to guess that placing people on Medicaid also does all of those things, yet that seems to be an appropriate solution in order to solve this problem, rather than trying to find affordable health insurance for individuals who simply are underinsured, cannot get insurance, fall into gaps where they do not qualify for insurance. And for us to be able to put forward something that does that, I don't think puts the state at risk for having to spend millions and millions of dollars over time such that we are in a fiscally precarious position, nor do we see even now that it wouldn't work, because we have people who, when they can afford health insurance, are going to get that. And built into this, and I can't stress this part enough, and it will be my last point, Madam Chair, built into this, not only in the actuarial pieces, which require us to not only look at the premiums, premium reduction, market adequacy, and what effect this would have on that, but also built into this is incentives for value-based healthcare that is going to provide for actual ability for folks to get the kind of healthcare that they need, and to make sure that what they are paying for is something that is going to help with long-term healthcare outcomes. So I thank the committee again for your very generous grant of time. I am very grateful for Madam Chair allowing me to indulge and rebut some of the points that were made, and look forward to having further discussions and hopefully earning your support. Thank you.
Thank you very much, Madam Majority Leader, and I truly hope that the elevators are working. Thank you. So with that, committee members, we're going to close the hearing on SB 420. We have some budget bills we need to move, so I'll give you a lay of the land. We're going to pull up a couple of them here. I've got 409, 421, 422, and 426. We're going to try to get through those if we can. And, I'm sorry? Oh, I'm sorry, 446. 446. So let's go ahead and open up the hearing on Senate Bill 409.
Good morning, Madam Chair and members of the committee. For the record, my name is Laura Freed. I serve as the Director of the Department of Administration. As you've noted, Senate Bill 409 is a budget implementation bill for the Division of Human Resource Management. To give you a brief bit of background, and I will keep it moving, I promise. When Senate Bill 135 was passed by the 80th legislature, it contained an assessment to support the Government Employee Management Relations Board, known to everyone as EMRB, to support their new workload of adjudicating disputes and certifying exclusive representatives for bargaining units. However, no assessment was provided for supporting the work of human resource management in coordinating the collective bargaining process. That includes working with the governor's designated representative, keeping records of class codes with exclusive representation, putting together the bargaining teams, scheduling the negotiation sessions, and otherwise interfacing with the union personnel in implementing the collective bargaining agreements. The existing personnel assessment was expected to be utilized during the current biennium to support the work of the Labor Relations Unit, and indeed it has been. And the committee might remember that we returned to the Interim Finance Committee to support the Labor Relations Unit position. So this bill takes the what the personnel assessment previously used to support labor relations and puts it onto a collective bargaining assessment in an equal amount. So, and what that does is establishes a policy nexus between the assessment paid and the benefit to the agencies that have represented employees. The assessment is per FTE per year for each position, that has an exclusive bargaining representative or could, in the case of no exclusive representative having been certified by the EMRB yet. And with that, I am most happy to take your questions.
So with that, if I understand this correctly, basically the folks that are in a collective bargaining unit and benefit from the collective bargaining unit will be paying the assessment for that, for participation in that. It's not being spread across all employees, it's being picked up by those folks. I just want to make sure that's clear because there's been conversations about folks paying for something that they're not getting, so. Ms. Freed?
Oh, yes, Madam Chair, for the record, Laura Freed. The agency, I want to note here that the assessment cannot be passed on to the employee. That's part of the bill, and that's true of the EMRB assessment as well. But yes, you are correct. The agencies that have those employees in those units will pay it, and then they will get they will substitute for what they used to pay in personnel assessment in this biennium.
All right, thank you. So with that, we're just trying to, I'm not going to say true up again because apparently I say that too much. So we're just trying to reconcile how this is being handled. Okay, thank you very much. So with that, committee members, are there any questions on SB 409? Not seeing any. Dr. Titus, a question?
Thank you, Madam Chair, and thank you for the presentation. I'm reading here there's a new fee. It's going to change an annual fee as opposed to a new fee. Can you clarify, please? Because it's not a 2/3.
And this is a budget implementation bill, and basically the fee that they would have been paying through our normal rate to human resources will now be adjusted to go in basically a different direction. So this is reconciling how those rates will be addressed for agencies that have collective bargaining units. So with it being in the budget, it's a shift that way. It's not a new fee, which would be a 2/3 notation.
Great. Thank you, Madam Chair.
You're welcome. So with that, committee members, any other questions on SB 409? Not seeing any. This is the hearing for SB 409. I'm going to go ahead and open it up. Is there anyone in the room in support of SB 409? Not seeing anyone in the room. Anyone in Zoom in support of SB 409? Not seeing any. Anyone on broadcast services? Do we have anyone on the phone line in support of SB 409?
If you would like to testify in support of SB 409, please press star 9 now to take your place in the queue. Chair, there are no callers on the line in support.
Thank you very much. We'll go to opposition. Is there any opposition in the room? Not seeing anyone come forward. No opposition on Zoom. Is there any opposition on the phone line, please?
If you would like to testify in opposition to SB 409, please press star 9 now to take your place in the queue. Chair, we have no callers on the line in opposition.
Do we have anyone in neutral in the room? Seeing no one in neutral in the room, no one on Zoom. Any neutral on the phone line, please?
If you would like to testify in neutral on SB 409, please press star 9 now to take your place in the queue. Chair, we have no neutral callers on the line.
So with that, I believe we can go ahead and come back to SB 409. Ms. Freed, I don't believe any other comments are necessary at this time. So with that, we can close the hearing on SB 409. We can open up the hearing on SB 421. Ms. Kaufman?
Thank you, Madam Chair. Senate Bill 421 changes the employment status of the Director of the Office of Science, Innovation, and Technology in the Office of the Governor from non-classified to unclassified status, and this is a budget implementation bill.
Thank you very much, Ms. Kaufman. Mr. Mitchell, please proceed.
Good morning, Madam Chair and members of the committee. Brian Mitchell for the record, and I'll be very brief. When OSIT was created, all employees were in the non-classified service like those of the governor, and the decision was made to bring agencies that are not in the unclassified classified service into unclassified classified service. And the executive budget recommends the conversion of the non-classified staff positions into classified and unclassified positions. And that is essentially what the bill does. I'm happy to answer any questions.
Thank you very much. I believe we had these conversations when we were hearing the budget also, so this is the implementation portion of that discussion point. Are there any questions from any committee members at this time? Not seeing any question from any committee members. This is the hearing for SB 421, so I'll go ahead and open it up. Or is there anyone in support in the room for SB 421? Not seeing anyone come forward. Anyone on Zoom? Seeing no one wishing to be recognized. Broadcast services, anyone on the phone line in support of SB 421?
If you would like to testify in support on SB 421, please press star 9 now to take your place in the queue. Chair, we have no callers on the line in support.
Thank you very much. Anyone in opposition in the room? Seeing no one come forward. Any in opposition on Zoom? I don't believe so. Broadcast services, anyone in opposition on the phone line?
If you would like to testify in opposition to SB 421, please press star 9 now to take your place in the queue. Chair, we have no callers in opposition on the line.
All right. Anyone in neutral in the room? Not seeing any. No one on Zoom. Any neutral on the phone line, please?
If you would like to testify in neutral on SB 421, please press star 9 now to take your place in the queue. Chair, we have no callers in neutral.
Thank you very much. I don't believe there's any closing comments that need to be made. We'll go ahead and close the hearing on SB 421, and we will open up the hearing on SB 422. Ms. Kaufman.
Thank you, Madam Chair. Senate Bill 422 establishes a new mail services division under the Department of Administration. And again, this is a budget implementation bill.
Thank you very much, Ms. Kaufman. With that, Mr. Tuma, I believe I see you there. There you are. Please proceed, Mr. Tuma.
Thank you very much, Chair. Yes, this is a budget implementation bill that would create a new division of mail services, and it would transfer the responsibilities of the central mailroom from the Division of State Library, Archives, and Public Records. So essentially continue the same services, but create a separate division due to the unique responsibilities of the mailroom. And so that being said, I am open for any questions.
And thank you, Mr. Tuma, very much. I think I'm remembering way back in the day when we moved it from where it was to the Library and Archive Services. So now we're moving it back. Okay, I guess I've been here too long. All right.
Correct,
No? Oh, Ms.
Chairwoman,
Freed's
it
shaking her
was-
head no. Okay, go ahead.
So it was not an independent division. It used to be under Buildings and Grounds in the State Public Works Division. And about a decade, it was moved from Public Works over to the State Library and Archives. And so it has never been a standalone division. And the unique mission of the roles and responsibilities are what is prompting this request.
Thank you very much for clarifying that. I appreciate that. I do remember that it did get moved. Okay, so with that, committee, not seeing any questions at this time, we'll go ahead and open it up for hearing. Do we have anyone in the room in support of SB 422? Seeing none. Anyone on Zoom? Seeing none. Broadcast services, anyone in support of SB 422?
If you would like to testify in support on SB 422, please press star 9 now to take your place in the queue. Chair, we have no callers on the line in support.
Thank you very much. Anyone in opposition in the room? Seeing none, no opposition on Zoom. Is there any opposition on the phone line, please?
If you would like to testify in opposition to SB 422, please press star 9 now to take your place in the queue. Chair, we have no callers in opposition at this time.
Thank you very much. Anyone in neutral in the room? Seeing none. Anyone in neutral on Zoom? No. Broadcast services, anyone in neutral?
If you would like to testify in neutral on SB 422, please press star 9 now to take your place in the queue. Chair, we have no callers in neutral.
Thank you very much. I believe that clarifies anything. I don't think there are any closing comments needed. We can go ahead and close the hearing on SB 422, and we can open up the hearing on SB 446.
Thank you, Madam Chair. Senate Bill 446 removes the Western Interstate Commission on Higher Education from the Office of the Governor. Senate Bill 446 further specifies, among other things, that the 3 Nevada State Commissioners of the Western Interstate Commission on Higher Education shall appoint a director which serves at the pleasure of the commission.
Thank you very much. So with that, Ms. Alette, if you could give us a brief overview, please. We've had a couple of conversations with you, so I think we're pretty well versed in this by now. So please proceed.
Thank you, Madam Chair. Senate Bill 446 is a budget implementation bill, and the committees approved the transfer of the WICHE program and the budgets from the Office of the Governor to NSHE, resulting in general fund savings of approximately $85,000 over the biennium. So SB 446 repeals the provisions that have the WICHE program and our budgets in the Office of the Governor and changes the appointing authority for my position, director, from the governor to the 3 Nevada State Commissioners. And I'm happy to take any questions.
Thank you very much, Ms. Olette. So with that, committee members, are there any questions at this time? Not seeing anyone wishing to be recognized, we can go ahead and open up the hearing for Senate Bill 446. Anyone in the room in support? Seeing none. Anyone on Zoom? I don't believe so. Broadcast services, anyone in support on the phone line?
If you would like to testify in support on SB 446, please press star 9 now to take your place in the queue. Chair, we have no callers in support at this time.
Thank you very much. Anyone in opposition in the room? Seeing none. I don't believe there's any opposition on Zoom. With that, broadcast services, anyone in opposition on the phone line, please.
If you would like to testify in opposition to SB 446, please press star 9 now to take your place in the queue. Chair, we have no callers in opposition at this time.
Thank you very much. Anyone in neutral in the room? Not seeing anyone. Anyone in neutral on Zoom? Nope. Broadcast services, anyone in neutral on the phone line, please?
If you would like to testify in neutral on SB 446, please press star 9 now to take your place in the queue. Chair, we have no callers in neutral at this time.
Thank you very much. With that, I believe we can close the hearing on Senate Bill 446. And hold on for just a moment. So with that, committee members, we have a few moments. We can go ahead and address SB 447 also, and then it's the chair's intention to move the budget implementation bills that we just heard. So with that, Ms. Kaufman, SB 447.
Thank you, Madam Chair. Senate Bill 447 eliminates the Consumer Affairs Division of the Department of Business and Industry and makes the temporary Consumer Affairs Unit in the department permanent. This is a budget implementation bill as well.
Thank you very much. Mr. Reynolds, nice to see you. Would you like to make a statement?
Yes, thank you, Chair Carlton. Terry Reynolds, Director for the Department of Business and Industry. The Consumer Affairs Unit has been in the Department of Business and Industry for the last, since 2011, actually, and each year it's had a sunset, each biennium, it's had a sunset provision in it. This removes that sunset provision. It also changes the name from division to unit, so it is now the Consumer Affairs Unit as indicated in 447. Just wanted to thank you for the passage of the budget for this, and we think this is a good step forward, and it gives the staff some security in terms of knowing that they're going to be continuing with that, subject to appropriation, obviously. But we have 6.6 staff members. We are a very small but mighty unit. Last year in 2020, they recovered $330,000 in restitution and products for the general public, and have done extremely well with about a 92 to 93% resolution rate for their cases that they hold. We did 2,500 cases during the pandemic time, and we average about 2,000 cases a year. So we really appreciate going forward with this bill. Thank you.
And thank you very much. And I know this unit, as we're going to call it now, has had a lot of history and a lot of moves, but they've always stepped up and done a very good job for the citizens of the state. So thank the staff for me that they were able to help the citizens that needed help. So we appreciate that. So with that, committee members, are there any questions on SB 447 of Mr. Reynolds? Not seeing any. We'll go ahead and open it up. Is there anyone in the room in support of SB 447? Seeing none. No one on Zoom. Broadcast services. Anyone in support of SB 447?
If you would like to testify in support on SB 447, please press star 9 now to take your place in the queue. Chair, we have no callers on the line in support.
Thank you very much. Anyone in the room in opposition? Seeing none. No one on Zoom. Broadcast services. Anyone in opposition on the phone line?
If you would like to testify in opposition to SB 447, please press star 9 now to take your place in the queue. Chair, we have no callers in opposition at this time.
Thank you very much. Anyone in the room in neutral? Seeing none. No one on Zoom. Broadcast services. Anyone in neutral on the phone line?
If you would like to testify in neutral on SB 447, please press star 9 now to take your place in the queue. Chair, we have no callers in neutral at this time.
Thank you very much. So with that, not seeing any other questions or comments, we can close the hearing on SB 447. And with that, committee, we're going to go into a work session, and the bills you just heard, we're going to send to the floor to make sure that our most important responsibility for the committee, other than the big budget bills, is to make sure all the budget implementation bills follow right along behind them. So the first bill that we'll work them in the same order that we just heard them. So Ms. Kaufman.
Thank you, Madam Chair. Senate Bill 409 requires the Division of Human Resource Management of the Department of Administration to charge an annual fee to the Executive Department relating to collective bargaining for state employees. This is a budget implementation bill. Laura Freed was Laura Freed, Director of the Department of Administrations, presented this bill, and there is no amendments proposed.
So with that, committee, any questions or comments? Hearing none, this would be a do pass, correct? As these are all clean, straight, oh no, yeah. Yeah, these are all clean, straight to us. So with that, this would be a do pass. I'll accept a motion from Ms. Monroe Moreno, a second from Ms. Bedinas Thompson. Questions, comments? Hearing none, all in favor, please signify by saying aye. Aye. Any in opposition? Hearing no opposition, passes unanimously of the members present. Moving on to the next bill, 421.
Thank you, Madam Chair. Senate Bill 421 changes the employment status of the Director of the Office of Science, Innovation, and Technology in the Office of the Governor from non-classified to unclassified. This is a budget implementation bill, and Brian Mitchell from the Office of Science, Innovation, and Technology presented this bill, and there are no amendments recommended.
Thank you very much. Any questions or comments from any committee members? Seeing none, I'll accept a motion to do pass from Ms. Monroe Moreno, second from Ms. Bedinas Thompson. Any comments? Hearing none, all in favor, please signify by saying aye. Aye. Any in opposition? Hearing none, passes unanimously of the members present. Moving on to Senate Bill 422, please.
Thank you, Madam Chair. Senate Bill 422 establishes the new Mail Services Division under the Department of Administration. Matt Tuma from the Department of Administrations presented this bill, and there are no recommended amendments.
With that, questions? Seeing none, this would be a do pass. Accept a motion from Ms. Monroe Moreno, second from Ms. Bedinas Thompson. Comments? Hearing none, all in favor, please signify by saying aye. Aye. Any in opposition? Hearing no opposition, passes unanimously of the members present. Moving on to Senate Bill 446, please.
Thank you, Madam Chair. Senate Bill 446 removes the Western Interstate Commission on Higher Education from the Office of the Governor. The Senate Bill 446 further specifies, among other things, that the 3 Nevada State Commissioners of the Western Interstate Commission on Higher Education shall appoint a director which serves at the pleasure of the Commission. Jennifer Ouellette, Director of WICHE, presented this bill. This is a budget implementation bill, and there are no recommended amendments.
Thank you very much. Any questions from committee members? Not seeing any. I would accept a motion to do pass SB 446 from Ms. Monroe Moreno, second from Ms. Bedinas Thompson. Comments? Hearing none. All those in favor, please signify by saying aye. Aye. Any in opposition? Hearing no opposition, passes unanimously of the members present. We'll go ahead and address SB 447 next.
Thank you, Madam Chair. Senate Bill 447 eliminates the Consumer Affairs Division of the Department of Business and Industry and makes the temporary Consumer Affairs Unit in the department permanent. Terry Reynolds from the Department of Business and Industry presented this bill. This is a budget implementation bill, and there are no recommended amendments.
Thank you very much. Any questions from committee members? Seeing none, this would be a do pass. I'll accept a motion from Ms. Monroe Moreno, second from Ms. Bedinas Thompson. Comments? Seeing none, all in favor, please signify by saying aye. Aye. Any in opposition? Hearing no opposition, passes unanimously of the members present. So with that, committee members, I believe our responsibilities for this morning are complete. We do have some bills left on our agenda to address. We do plan on coming back this evening, depending upon the policy schedules this afternoon. So we will go into recess. I hope that we can be back in the room at approximately 6 p.m., but I cannot guarantee that. We do need, the policy committees have been very nice to let us get our work done those couple of days. We need to let them get some work done today. So we will try to get back in here at 6 p.m., but This time of session, that's not a guarantee. So with that, we are in recess.